that we are online and people who have joined us. So I would like to welcome all of you to the 2021 fall meeting, the breast committee meeting of SWOG. It's a great disappointment that we couldn't meet in person yet again, and we're missing out on, I think, the very valuable personal interactions that happen in the corridor. I hope that this is going to be the last time that we have to do this online. We have a really exciting sort of portfolio of presentations, keeping with our old tradition of starting with a scientific symposium. And subsequently, we will review our clinical trials, the progress of the studies which are open, and also the new studies which are in the pipeline. I would like to ask you that if you have questions, you will need to place this into the chat box. And I will read them out for the presenters or for the relevant person that you are placing it to. I take that you all see the meeting agenda, and I will move on to introduce our mini symposium speakers. So we are very fortunate to have my former colleague, Dr. Mittendorf, Elizabeth Mittendorf, who is professor of surgery at Harvard Medical School and the Robin Karen Hill Distinguished Chair of Surgical Oncology. Elizabeth actually had the foresight to study cancer immunology and tumor immunology at a time when none of us really believed that this would work. And of course, lo and behold, most of us were wrong, and she was right. So she's going to give us an update on the current state of art of immunotherapy in breast cancer, which is an exciting thing because finally, immunotherapy has arrived in breast cancer as well. Elizabeth, the floor is yours.
All right. Thanks, Lars. I appreciate that kind introduction. Somebody once suggested that I did immunotherapy before it was cool, which I thought was a interesting description. Let me see if I can get it to display appropriately. All right, does this look like a view a presenter view?
I think the previous version was better.
I mean, we don't really see what the audience sees, but we see your slide now in full screen.
You're seeing it in full screen now?
Yes. I do.
Yeah, that looks good.
Okay, great. So yeah, thank you all for inviting me to join you. It's, as Lyra said, it's a shame that we can't be together in Chicago, but hopefully we'll have, I hope, 3 nice presentations and discussion to follow. So these are my disclosures. And then this is a slide that I've used in a couple of slide decks and talks recently, where I note that immunotherapy, in fact, is now approved for use in breast cancer, specifically in Pdl1 positive metastatic triple negative breast cancer. And prior to late August, what I would suggest was that approval came based on the results of 2 trials. So in Passion 130, that looked at atezolizumab plus nab-paclitaxel versus placebo plus nab-paclitaxel in patients with metastatic triple negative breast cancer. This was a study that accrued over 900 patients, and it showed a benefit with respect to progression-free survival for patients whose tumors were Pdl1 positive. And then on the right-hand side of the screen is the trial that led to the approval of pembrolizumab, which is Merck's compound, a similar trial, Keynote 355, in that it enrolled patients with metastatic triple negative breast cancer and randomized them to either pembro plus chemo or placebo plus chemo. A little different in that it was a 2-to-1 randomization and different chemo backbones, but nonetheless, the result was similar in that it showed a benefit with respect to improved progression-free survival for patients receiving pembrolizumab, specifically in the group of patients who were Pdl1 positive, defined as a CPS greater than 10. And I'll be speaking just very briefly about the Pdl1 assessment because I know Dr. Rim is going to follow me and give a wonderful presentation on the subject. As I mentioned, and actually let me go back, you see I have now put an asterisk in this slide, and that's just to remind myself that, in fact, Genentech voluntarily withdrew U.S. accelerated approval for Atezo in late August, and that's in part because of the failure for the confirmatory study to read out as positive. So what I want to do is just go through a little bit more of the Keynote 355 data, specifically the data that was presented at ESMO here just a few weeks ago. And so a reminder for the scheme of the trial, a 2-to-1 randomization, pembro plus chemo versus placebo plus chemo. The primary endpoints of the study were to look at PFS in patients who had Pdl1 positive tumors. And you'll note that they had two predefined cutoffs for CPS scores, greater than or equal to 1 and greater than or equal to 10. And then to look at that same endpoint in the intention to treat population, same with overall survival. And then there are a number of secondary endpoints that Dr. Rugo reported out at ESMO that I'm not going to spend much time talking about. So these are the baseline characteristics of the 847 patients that enrolled on the trial. Median age 53. You can see here that about 75% were positive for Pdl1 if it was a low score of 1. But for the score of 10 or greater, it was about 40%, which actually kind of mirrors about the percentage of Pdl1 positive patients we'd seen in Impassion 130. This then is the most up-to-date overall survival analysis for the intention to treat population. What you see here is the pembro group in the teal, the placebo in the maroon, and there is a slight benefit favoring pembro, but certainly not statistically significant in this intention to treat population. What about the low Pdl1 positive, so those with a CPS score of 1 or greater? Again, a slight benefit to pembro, but it did not meet the pre-specified boundary of 0.0172 when you look at that p-value. Where there was a statistically significant benefit was in the patients who had the higher Pdl1 positivity, a CPS score of 10 or greater, the overall survival of 23 months for those receiving pembro, compared to 16 months for those receiving placebo. And again, it did, in this case, meet a pre-specified boundary. I wanted to highlight a few things in some of the subgroup analyses for overall survival performed in the CPS greater than or equal to 10 group. One thing that I would note is that it actually seemed to favor patients that receive Taxol, paclitaxel. And I highlight that because I am going to show 1 or 2 slides about Impassion 131, and I think it may be relevant for that discussion. The other thing that I would note is that, as one would anticipate for immunotherapy, arguably for any agent, it seems to be more effective for patients earlier in their disease course, so de novo metastases, or if they've had a longer disease-free interval. And then this is the up-to-date data looking at the progression-free survival. On the left is for patients with a CPS score of 10 or greater, then CPS score of 1 or greater in the middle, and the intention to treat on the far right. And again, what I've put at the bottom, just so that we can see it, not have to do the math, about 38% of the population was a CPS of 10 or greater, and that is the group that derived statistically significant PFS benefit. And then last, but certainly not least, as we all know, now that we are using these agents in the clinic, one of the things that we have to be quite cognizant of is the fact that they have a different toxicity profile, perhaps, than chemotherapy or other targeted agents that we've become familiar with. And what I'm showing are the immune-mediated adverse events. The most common in all of the trials to date really is around thyroid, hypo and hyperthyroidism. You can see here they also had patients that developed pneumonitis, colitis, and then some severe skin reactions. And so, again, what I think is notable is that breast clinicians, now that we are using these agents more frequently, have become much more adept at managing these toxicities in our patients. So I do want to have just a slide or two about atezolizumab, because to be quite frank, I don't think it's a bad drug. I think it probably is effective in select patients, and I'm going to just make some comments about that. I mentioned that it had initially been approved based on the results of Impassion 130. This was that first analysis from Impassion 130 reported in the New England Journal by Peter Schmid, and it was based on this improvement in progression-free survival from 5 months in the placebo group to 7.5 months in the atezo group that led to the FDA granting accelerated approval for atezolizumab. Now, you all will recall that there was that 10-month Pdl1 positive, or excuse me, 10-month overall survival benefit in the Pdl1 positive population, but due to the statistical design of the study, they didn't assign a p-value to that. But if you recall, back when this was first reported, it was really eye-opening or eye-popping or exciting that we had something that had shown a 10 months improvement in OS for these patients. So the confirmatory study, as I believe you are all aware, was Impassion 131. So this was a study that also enrolled patients with metastatic triple-negative breast cancer. You can see here it was a 2-to-1 randomization, and now instead of using nab-paclitaxel, they paired it with paclitaxel, and you can see here that there was some use of dexamethasone early in the patient's course of treatment. The primary endpoint of this study was PFS as assessed by the investigator. And this is the data. So this was presented at ESMO in 2020. This is the PFS for the intention to treat population, no benefit to atezo. This is the PFS in the Pdl1 positive population, no benefit to atezo. And then here is the overall survival data. And there's no statistical difference between these two groups. You could suggest that, in fact, the placebo group did a little better. And I think it's actually kind of interesting to note the OS of 28 months in the placebo group. It just seems to me that the placebo arm kind of outperformed what we would have anticipated. But a negative study, and based on this, I think this was really what caused Genentech to have limited enthusiasm for continuing to pursue that approval. And as I mentioned, they withdrew their accelerated approval in August of this year. So where are we with immunotherapy in metastatic triple-negative breast cancer? Well, pembrolizumab is now the only approved immunotherapeutic agent for these patients. It is restricted to patients with Pdl1 positive disease. And one question that'll come up, and I think David will give us a tremendous talk about, is what is the best assay to test the Pdl1 status? I think there are a number of open questions, biomarkers being one of them. Pdl1 is a biomarker, but there's others that we need to define that help us determine who's going to respond to this treatment, and perhaps importantly, who's going to experience toxicity with this therapy. And then when we think about the biomarkers, what's the best site to test? As you all know, I haven't spent much time talking about it, but in order to go on these trials, there were different protocols with respect to whether you could use an archival specimen versus a newer specimen. And some had the primary tested, some had the metastatic site tested. And so some of that remains to be determined. What are we going to do with our patients who have Pdl1 negative disease? And I think that's something that, as we consider future clinical trials, something to consider. Is there a way to make patients who have Pdl1 negative tumors Pdl1 positive, who then may benefit from the addition of pembro or other similar immunotherapeutic agents? And then what to do on progression. And then I still think there is a role for looking at the question of whether or not immunotherapy as monotherapy might work. I'm going to show just a few slides, not to step on David's toes, but to make a point that I want to make about trial design. So I've referred to, in the trials I've discussed today, just Pdl1 positive. And what is important to note is that the way that Pdl1 positivity is assessed and determined varies depending on the agent, therefore on the company. And so what I'm showing here are the two for the trials that I've discussed. So for Roche, Genentech, and atezolizumab, they use the SP142 antibody and determine what's called the IC score. So it's the percent of immune cells that are positive for Pdl1. And then on the bottom is the 22C3 antibody, which is what Merck uses to determine their CPS, or combined positive score. And this is really looking at the extent of Pdl1 expression on both the tumor and the infiltrating immune cells. And so again, back to the 130 study, what we found in that study was that the PFS and OS benefit was restricted to those who are Pdl1 positive by the SP142 assay. And what I would note is that their definition of positive was stating on at least 1% of immune cells. And what I would highlight is that's kind of a binary variable, either present or absence, even though they defined it as 1%. And then again, I've already shown these data looking at the PFS in the Keynote 355 trial, broken down by the Pdl1 status as assessed by the 22C3 assay. And what you note here is the difference between CPS greater than or equal to 1 and CPS greater than or equal to 10. And so these are some of my thoughts on this, using Pdl1 expression as a biomarker, specifically as we think about these two clinical trials. So in Impassion 130, they used a binary present-absent cutoff. So they were really not able to look at potential benefit in the highest Pdl1 expressors. And they actually designed that trial without knowledge that Pdl1 expression would in fact be a biomarker. And they were not powered to look at OS in the Pdl1 positive subgroup. So I don't know if all of you are aware of this, but in the Keynote 355 trial, they actually revised their statistical plan just prior to an interim analysis that allowed them, and this was all above board, I'm not being critical, that allowed them to look at the CPS greater than or equal to 10 population. So if they hadn't changed that and they're only looking at CPS greater than 1, Keynote 355 would have been a negative trial. And so I kind of think from a trial standpoint, and that's what this group is kind of thinking about, clinical trials, and obviously this is why we have people like Dr. Barlow to help us be quite thoughtful in our statistical plans. Pdl1 being a biomarker, it kind of hurt in Passion 130, and it helped Keynote 355. Real briefly, is there a role for immunotherapy as monotherapy? I know that the beginning of immunotherapy in breast cancer looked at it as monotherapy and it failed. And that's what led us to looking at it in combination with chemotherapy. But with our experience, I think we might have a little insight into populations that may in fact benefit from monotherapy. And I'm referring specifically now to the Keynote 119 trial that looked at patients with metastatic triple negative breast cancer, 1 or 2 prior lines of therapy, and randomize them to either pembrolizumab or investigators' choice of chemotherapy. And what I would highlight, negative trial, but if you look at the patients broken down by their CPS scores, you begin to see for those who had the absolute highest CPS scores, so CPS of 20 or greater, that it looks like we could see some benefit. So I guess in my opinion, this is still a question that may be worth asking. And it's possible that the NCTN is the right place to do such a study. I want to turn my attention now to the neoadjuvant immunotherapy trials. I've listed a number of trials here that I think are the important ones. I'm going to begin with Keynote 522 for probably obvious reasons. It's what's led to an approval for pembrolizumab in the preoperative setting. So this is the trial schema. It enrolled patients with newly diagnosed triple negative breast cancer, basically stage 1 or 2, 2 or 3. It was a 2-to-1 randomization to chemotherapy plus pembro versus chemo plus placebo. And one thing that gets talked about quite frequently is the actual chemo backbone. So you can see here it was carbotaxol followed by an anthracycline cyclophosphamide. Patients that underwent surgery and then they continued on either pembro or placebo in the adjuvant phase. There were co-primary endpoints of PCR and EFS. And again, I would suggest kudos to Merck and the study statistician to have these co-primary endpoints. It made it a larger trial. It enrolled 1,174 patients, but allowed them to get that EFS data, which is what I believe the FDA really weighed when they were considering the approval. And so this is the very first report of the PCR, and this is in the intention to treat population. And what you see is that there is an improvement in the PCR rate from 51% to 65%, so a delta of about 14% for patients that receive pembrolizumab. And then trying to look at which patients might have benefited the most, one of the things that I've found quite interesting with these data is that it appears that it's the node positive patients who derive most of that benefit. You can see here that the delta in the PCR for the node positive patients favoring pembro is about 21%. A very important analysis was looking at PCR by Pdl1 status. And I say very important because what you see here is that in fact, patients whose tumors were either Pdl1 positive or negative derive benefit. And as you know, the approval is agnostic to Pdl1 status. This is their first EFS report at their first interim analysis. And at that time, even though it favored pembrolizumab, it didn't cross their pre-specified boundary. And so as we all know, as a breast cancer community, we've kind of watched them go through their interim analyses. This is interim analysis 3 when they actually first went to the FDA and were not approved. Again, benefit to pembro, but didn't cross their pre-specified boundary. But then here in July at the ESMO virtual plenary session, they showed their fourth interim analysis where the benefit now 84.5% EFS for the group that got pembro versus 77% for the placebo group, significant benefit that now did cross their pre-specified boundary. And then data that I think is quite interesting is looking at that EFS by PCR. So again, what we've seen here is what we've seen previously in our work, and that is that if you experience a PCR, you will do well. What I think is interesting is for those patients who don't experience a PCR, those are the patients who seem like they really do, if they do benefit quite a bit from getting the pembrolizumab, the immunotherapy. And then just a last slide, because I find it interesting, you know, the initial report and publication in the New England Journal had that improvement of PCR of 14%, but that was at an interim analysis that occurred when 600 patients had come to surgery. When they look at the entire trial, so at their third interim analysis, when all 1,100 patients had come to surgery, that improvement in PCR actually shrinks. So we're seeing that EFS benefit even as we're seeing a smaller PCR benefit than we saw with the initial reports from the study. Very quickly, Impassion 031 is a very similar study that looked at the addition of atezolizumab to chemotherapy, a different chemo backbone, nab-paclitaxel and AC. This is a smaller trial, only 333 patients, and the primary endpoint was PCR. And so this is a study that's not powered for EFS, DFS, or OS. They will be reported, but again, not reported for that. And much like we saw with Pembro, the addition of Tezo results in an improvement in the PCR rate. The delta here is about 16.5%. Much as we had seen with the Keynote trial, appears that the biggest benefit is in those patients with with node-positive disease. And again, it doesn't seem to matter whether the patient's tumor is Pdl1 positive or negative. I'm not going to spend much time talking about it, but AEs are critically important, obviously, in a curable patient population. And again, thyroid toxicity is the most common, and some of this can be lifelong. In the interest of time, I'm going to skip through some of the PRO data and just kind of skip to the summary about immunotherapy in early stage triple negative breast cancer. So Pembro was approved based on this improvement in EFS, and it was approved for use regardless of Pdl1 status. And we don't really have any biomarker data available yet from Keynote 522, at least that I'm not aware of. And the point that I would make is that, in fact, with approval for all patients with triple negative breast cancer, our pharma colleagues are, in fact, not incentivized to identify a biomarker. So again, I think it's up to us as academic groups and cooperative groups such as SWOG to think about how we might want to work to identify a biomarker, primarily because of the toxicities associated with these agents. I think it makes it critically important that we're identifying those patients who are most likely to benefit. And I apologize, Priyanka or Elias, did I have 20 minutes or 30 minutes? Because if I had 20 minutes, I'll tie up.
20 minutes.
Okay, so I'm going to just skip through some things. This was just to show you where we are with respect to biomarkers. At the end of the day, we know from the JPAR Nuevo study that did have a pretty sophisticated correlative study plan that has been reported out that TILs, Pdl1, tumor mutational burden, the gene expression profiles, they predict response to neoadjuvant treatment, but they don't differentiate who's responding to the immunotherapy in combination with chemotherapy versus those who are responding to chemotherapy alone. So much work to be done. I just highlight that one NCTN investigator, primarily aligned with ECOG Akron, Justin Balco, has been looking at MHC class 2 as a novel immune biomarker. And Laios, this is a report that is data from a study that you ran, where he is proposing that, in fact, MHC2 can differentiate between the response to chemotherapy and immunotherapy. And so with respect to early stage triple negative breast cancer, Pembro is approved in the neoadjuvant setting, regardless of Pdl1 status. I think there are a number of open questions, is one being, can we identify who's going to benefit from IO? Our group at Dana-Farber, certainly for node positive patients, and then patients with tumors greater than 3 centimeters is kind of what we're looking at. And so we actually did a little analysis here about a week ago, looking at NCDB data as well as our own institutional data. And what I would highlight on this slide is just that if you look at your clinical T1C, about 15% of patients in our Dana-Farber population, about 12% in the NCDB, these are patients who are clinically node negative and went to surgery first and were found to be pathologically node positive. And on the bottom of the chart, you see the rates of nodal positivity in the clinical T2N0 broken down by tumor size. And so with that, the other questions I think that are open and perhaps will be discussed in your meeting today, what is that optimal chemotherapy backbone? I've already highlighted the need for biomarkers differentiating response to immunotherapy, as well as for identifying patients at risk for toxicity. And do we even need to continue pembro in the adjuvant setting if a patient experiences a PCR? And I think Dr. Sharma will be talking about that when she reviews some of the active efforts of the different NCTN groups. So I apologize for running over, and I thank you for your attention.
Thank you, Beth. This is a really comprehensive review. I'm going to break protocol, and I will ask you a question that came up in the chat, because I think this is a question that every one of us actually is wondering about. So why is Pdl1 expression important in metastatic disease to select patients for therapy, whereas it doesn't seem to be important at all in the early stage setting?
Yeah, so I think one thing that I would comment on is that, in my opinion, the tumor microenvironment is quite different in the metastatic setting than in the preoperative setting. And as far as why it's probably important in the metastatic setting versus the neoadjuvant setting, I don't know that we know. In fact, Laios, I feel like I should let you answer this question, because I've heard you speak to this before, and I thought you had a theory about this. But one thing I would emphasize is that Pdl1 expression really is a dynamic biomarker. And one thought, and David may be about to talk about this, I don't know that, the way that Pdl1 was assessed on those trials, I don't know that we should really say it is in fact a biomarker. I think work to be done there. But Laios, this is unusual for me to do, but maybe I will kick it to you, because I have heard you speak to why you think in the neoadjuvant setting it's not, and your answer was a little more sophisticated than mine.
Yeah, I'd love to discuss this, but I think you probably won't have. So I'll cut and paste a manuscript link into the chat room, but I completely agree with you. I think the immune microenvironment is very different. It's much more immunosuppressed, and you can measure this in many different ways beyond just the Pdl1 expression in the metastatic setting. And probably it's easier to ignite an immune response in the early stage setting than in late stage setting.
Yeah.
So you need a much more massive immune presence that's reflected by the more abundant Pdl1 expression in those tumors, which have a lot of immune cells. But this is a very good segue to actually introduce David, who's going to talk about the vagaries of Pdl1 testing and how it relates to TIL counts and immune infiltration. So thank you, Beth, again. And David, so David is a professor of pathology and probably the world expert on Pdl1 staining. And he also leads the Yale Pathology Tissue Resources, and I'm really so fortunate to have him as a colleague. So David, please, the floor is yours.
Okay, thank you very much. And thanks also to Dr. Mittendorf for an excellent setup for this presentation. It's also very informative to see a surgical oncologist give the surgical oncology view. Now I'll give the pathology view. The reason that the trial failed was that the assay was bad. And to quote Dan Hayes, a bad assay can be worse than a bad drug. And I think that's really the problem here. And I'll try to convince you that, in fact, Pdl1 is a great biomarker. Unfortunately, we don't yet have a good assay for it. So these are my disclosures. And you can see a lot of the work that we do is actually funded by biotech and pharma. But that said, we can go and look at the assays that I've talked about. These are the assays for the checkpoint inhibitors. So there's actually more than that for now. This is a little bit outdated, but these are the 4 key ones that we know about. There's also an LDT called E1L3N that we use here at Yale. And there's also a few other assays that are less popular that are also being done for various smaller activity drugs. You can see the assays, the vendor of the assay, and then the drugs are over here on this column, and then what indications there are. And you can see that the green check marks are when it's a companion diagnostic, which means, as you know, you got to do it to prescribe the drug. And it's notable that in breast cancer, there were 2 in the first-line metastatic breast cancer, and none in neoadjuvant, but that these 2 were actually in conflict with each other and caused a huge stress for pathologists, because they had to know how the patient was going to be treated before they decided which assay to do, or they could do both assays, both of which are poorly reimbursed, and they lose money on every assay they do. So this set up a problem for pathologists that was taken care of by the fact that Roche voluntarily withdrew the accelerated approval, as you all know. So now I want to talk about the process. And because I only have 20 minutes, I'm only going to talk about the examination by the pathologist, or the analytic or interpretive part of the assay. An equally important assay, in fact, more important for SB142, is the pre-analytic or the biochemistry part. Suffice it to say, since I don't have time today to go into that SP142 is about half or a quarter as sensitive as all the other assays. And I'll get into that a little bit. But first, let's describe how the assays are read. So the assays are read with various scoring systems. The tumor proportion score, TPS, is the percent of tumor cells that are positive. And the IC, the immune cell scoring, as read by originally by Merck and by BMS assays, or the 22C3 and the 28 assays, was the percent of immune cells positive. At the Genentech, Roche decided that actually IC was the percentage of area covered by Pdl1. So just to add confusion to confusion, we have two assays that have the same name, or reading systems rather, that have the same name, but for different assays, there are different definitions. And then finally, worst of all, is CPS. CPS means combined proportion score, and I'll spend a lot of time on that later. This is what I look at, or what we look at when we sign, what the pathologists of the world look at when they sign out an IHC. This is an easy one. This is tumor proportion score high, greater than 50. For tumor proportion score, we wisely divide it up into three categories: less than 1, 1 to 49, or 50 and greater. And this is an easy one. It's clearly high tumor proportion score, greater than 50%. And these patients, especially in lung cancer, do great. They respond, and they don't even need chemo with their pembrolizumab. In fact, monotherapy works. As Beth was indicating, maybe if Pdl1 is high enough, you can get away with monotherapy. But you can also see the immune cell staining here, and you see sort of this diffuse staining, where in the tumors, the protein is on the membrane. In the immune cells, we don't know what these are, but there's been suggestions that they're macrophages, dendritic cells, and possibly T cells. We see the cells sort of cytoplasmic staining. Here's another example that's perhaps more representative: less distinct immune cell staining and a range of tumor staining on the membrane. And we're told to read any intensity. That means this is 100% positive, not 50% positive, because they all have some membranous staining of Pdl1. Here's another example. So this cell here has very light Pdl1 staining. Can you see my arrow? Or should I use maybe I need to use the laser pointer here. Hold on. Can you see that?
Yes.
Okay, so the laser pointer is showing a cell with very light membranous staining, or this cell with very light membranous staining, then stronger membranous staining. Since we call any intensity, we don't worry about this heterogeneity. But biologically, don't you think we should? But we don't, because we're reading this subjectively, not quantitatively. And so we just call this any staining. And so this would be a greater than 50% case. What about this case? This is a real challenge for some pathologists, and a reason that there's a challenge of concordance for all of these assays. This is not tumor staining. This is macrophages that are intercalating between the tumor cells. These tumor cells and the membrane of these tumor cells out here where my laser pointer is are negative. But there are macrophages that are intercalating these cells that are strongly positive for Pdl1. So this would be called a tumor cell negative, immune cell high. And if we had to estimate the percentage of area, we might even see greater than 10%. And I won't even go into CPS yet. But this is all lung cancer that I'm showing you, because this is where it all started. And that's how we made our definitions. Let me show you a few more examples and one of the problems. The problem is that, and when you look at a tumor, a pathologist has to look at the entire section, not just one or two fields of view. And so if you look at field of view A, you would say, oh, sure, that's greater than 50% membranous staining. That's Pdl1 positive. But if you look at field B, you can see it's really only immune cells that are staining, and there's hardly any membrane staining. So somehow in our head, we have to integrate this with this and give you an accurate score that's reproducible. This is a problem for pathologists. It's a problem for human beings. And this is why I think that a lot of the tumult around the assay is not because that we don't know about the biomarker, it's because we don't know about the assay. And to further complicate things, in lung cancer and to a lesser extent breast cancer, you see entrapped macrophages. These are not tumor cells. These are macrophages that are strongly expressing Pdl1, and they're entrapped within the tumor and within the inflammation here in this tumor. And that came from this region here, C. So it's not the edge of the tumor. Yeah, on the edge of the tumor, there might be some strong macrophages as well, but it's right in the middle. So we have to read this. So this is not a straightforward reading and could lead to pathologist discordance. But this was lung cancer. What about if we look at breast cancer? So here's a breast cancer case. This is stained with SP263, not approved for any assay, although used in Europe and used in the US to some extent, originally partnered with the Devaluimab therapeutic. And you can see, again, this looks pretty similar to the E1L3N stainings that I was showing in the previous slides, or 22C3 in the previous slides. And you can see that there's sort of a bland cytoplasmic staining across the immune cells, but essentially no tumor cell staining. This is the problem in breast cancer. When you talk about CPS, it's almost meaningless. It's essentially the same because almost no breast cancer cases, probably less than 3%, show any tumor cell staining. So in breast cancer, we're really reading immune cells. But in the original assay, we read them in SP142. This is the same case, okay? Hard to read, impossible to read. And this is why I think the Impassion 131 trial failed, is that this assay is just too hard to read. They have not as much primary antibody, which leads to lower sensitivity, which leads to less signal, which led to a lot of discordance, which I'll show you again. Even in a high case, and this is a high case, you can see more staining, but these cases were pretty rare where you saw this much staining, probably less than 5 or 10% of the cases. And even then it was hard to read because what happened to generate this, presumably there's too much first antibody or not enough first antibody and too much second antibody. This is an artifact that we try to avoid, but for some unknown reason to me was built into the test for SP142. So there haven't been a lot of studies in breast cancer, and this is one that looks at 79 cases using whole slide imaging for SP142. There have been no studies that I know of for 22C3 in breast cancer. There is some 22C3 concordance studies for CPS and other tumor types. What was the result? Well, the result, it depends on how you look at it. The conclusion was the findings show substantial agreement of Pdl1 and SP142 assessment if you consider substantial agreement 62%. If we told you that we're going to make the correct diagnosis 62% of the time, you'd fire us all and send your specimen somewhere else. But this was considered by this very prestigious group at Memorial Sloan Kettering to be pretty good for this assay. This is what I mean by a bad assay, is that if the best pathologist in the world can't agree 100% of the time on an assay, you probably need a better assay. So let's look at the assay. Since there isn't any prospective multi-center literature on breast cancer, let's look at lung cancer, where there are two prospective multi-institutional studies for assay comparisons. There was one that I led with NCCN that had 13 pathologists across about 7 different sites. And then there was one that was led by Fred Hirsch and Ming Sao Sam that was 25 pathologists across 15 sites. And what they found is that the TPS for the assays, this is the interclass correlation coefficient, so it's not overall percent agreement now. Interclass correlation coefficient for TPS was quite high. That is, anything above 0.75 is really good, and 0.88 is terrific. And here you can see that they're all, on average, all 4 of the assays, well, 3 assays that are FDA approved and an LDT in this case, had an interclass correlation coefficient of 0.86. However, for immune cells, the interclass correlation coefficient was below 0.2, which is unacceptable. We can talk about the cutoffs, and you can also see that the agreement was much higher in Kappa concordance or Kendall concordance for the 50% cutoff than it was for the 1% cutoff. This is for TPS, not for IC. Let's look at the second study. The second prospective multi-institutional study was better because they had a 1.5-day training course for each of the pathologists. The previous NCCN study was criticized for not training its pathologists. So how did they do? Well, they did exactly the same. They did 5 FDA-approved assays and found that whether they did it digitally or on glass slides, the ICCs were between 0.8 and 0.9 for tumor proportion score. But for immune proportion score, they were down in the 0.1 and 0.2 range, even after a day and a half of training, showing that the problem wasn't training, it was the assay itself. So in summary, there's 2 statistically powered multi-institutional studies and a number of smaller studies. There's probably 40 or 50 now smaller studies, and I'm not going to show those because they usually are 3 or 4 pathologists and 30 or 40 cases, so they're not really powered. But what you can see is that 22C3, 28.8, and 263 are practically equivalent, while SB142 shows lower score, uniformly lower scores on both tumor cells and immune cells. I didn't show you that data. But the pathologists can read TPS with high concordance, but even with training are not concordant in reading immune cells. And for the NCCN study, we showed that we could use this LDT equivalently with the FDA-approved tests. So now let's talk about CPS, because that's what's left in breast cancer. That's what's approved in breast cancer. And in CPS, we have to count the Pdl1 positive tumor cells plus the lymphocytes plus the macrophages, and we divide that by the number of total viable tumor cells and multiply times 100. And this is a guide that helps you. This is from the label. Actually, this is from the 22C3 label. So I'm not making this up. This is how we do it, and this is what helps us. And so you can actually take a course in how to do this, which I did. And Adjuvant shows you, first you look at 40x and you check out the landscape, making sure there's initial estimate of % positivity, and you can see some positivity. And then you can go to a little higher power and a little higher power. And then you might even want to divide your region up and then make the average of this. And then you can ultimately come up with a CPS score using the formula that I showed you. But there's no published validation of this. They just made this up. And so when I asked the instructor, I said, well, where's the paper that shows that this works? Did you compare it to anything? They said, no, but it makes sense, doesn't it? Well, not exactly, because this is the image we have to convert. This is, if that was the case for this image, that would be fine. But how do we convert this into counting the number of immune cells here? Impossible. Clearly, this is, well, to a pathologist anyway, or some pathologists, this is immune cell staining cells intercalating with long dendritic processes between tumor cells. But how do you equate that to something like this? And then how do you come up with a CPS score? So what happens in the real world? Well, we found out. It turns out that I sit on the College of American Pathologists Immunohistochemistry Committee, and we survey labs, and they have to take the surveys to keep their certification. And so we asked them a couple of questions. How does your laboratory interpret Pdl1 testing for CPS? Eyeball estimation, manual counting, or tests not performed? If we combine, the manual counting happens in about 2.5% of the labs. And for Pdl1 testing for IC, not CPS, manual counting happens in about 2% of the labs. So we're not doing what they say. And CPS, I would argue, is probably maybe not a very reproducible assay, and maybe is the problem with these clinical trials that are using this assay. So here's the package insert as well. And you can see this is a package insert from head and neck usage of this. And they wanted to use CPS 20. How did it work out? Note, the study failed to meet pre-specified acceptance criteria for inter-site positive predictive agreement for CPS greater than 20. So it failed. And so that's why for head and neck, we just have greater than 1 as a cut point, not greater than 20 as a cut point, even though the data from the head and neck studies showed that greater than 20 was much better, and you could see effect without chemotherapy, like was seen in the study that Dr. Mittendorf showed in the neoadjuvant setting in breast. But we can't make these diagnoses, and that's the problem, is that even there are training programs that suggest we can do CPS, and we're told in advertisements that we receive in our email that patients are relying on us for accurate Pdl1 interpretation, so we should go enhance our skills. But there's limits to what people can do. Human beings can't fly, and you can't train us to fly unless we use some tool, like an airplane. And I think what CPS is, or what Adjuvant's trying to get us to do, is to do something like human beings flying. And I just think it's out and out impossible. So let's look at the safety and effectiveness document from the FDA approval of 22C3 in breast cancer. Here it is, and they show what the cut points are and all the companion diagnostic indications right now. And then they show, and this is the pathologist view of that same thing that was published in Lancet Oncology, but this is from the safety and effectiveness document, that if CPS is greater than 10, you get statistically significantly better survival. But then if you look at the inter-observer for precision for CPS greater than 10, overall it's 92%. That's pretty good, better than 90%. So it got approved. The 88% was CPS greater than 20 in head and neck. It failed. So do you think this is going to work? Do you think this is real? Well, I'm worried about CPS. I think CPS 1 might work because it's like estrogen receptor. It's greater than 1 or it's less than 1. But CPS 10 might be more of a challenge. So I want to show you what happened. I want to take a few more minutes. I think I have 5 more minutes here to talk about the conundrum of how the FDA approves this. That is, how did the pathologists come up? What does inter-observer precision mean? And all tissues were scored by 3 certified pathologists at 3 different sites. That's what it really is. But actually, the way the FDA defines comparison is overall percent agreement, 93% for the Adjuvant assay here, to show interclass correlation between 2 observers. That is a consensus. I'm sorry, I changed the slide and I screwed up here. I meant to say Adjuvant, not Ventana. But the way the FDA requires is they make a consensus score amongst all the observers, and then they compare each individual observer, and there are only 3, to the consensus score. So that's really like comparing just one observer to a second observer, because there's only 2 scores. Whereas the NCCN trial had 13 observers, and the Blueprint trial had 25 observers. Maybe that's why in the Blueprint trial, we got an ICC of 0.2 or 0.1 or 0.3, where the FDA for 22C3 got 93%. So which is going to happen in the real world? And is there a way to determine how many observers are needed to mimic a real world assay performance? So I showed you a bunch of assay reproducibility comparisons. We talked about interclass correlation coefficient. We talked about correlation coefficient and kappa and Fleiss briefly. And the FDA uses overall percent agreement. So that's probably what we should use for comparing our assays, since that's what the FDA used. But no method, at least no method that I could find, to determine the number of observers that you need to show rigorous reproducibility between observers. So we made one up. We call it observers needed for the evaluation of subjective tests, or an honest plot. And we plot the number of the overall percent agreement, the FDA's agreement criteria, on the y-axis, and the number of observers on the x-axis, with the idea that if an assay is bad, the more observers you have, the lower you'll be. And if that assay is good, the better it will plateau, even as you have many, many observers that will all kind of agree. And in fact, that's what happens with estrogen receptor. This is a separate study that we did that's not published yet, where we had 17 expert breast pathologists read 160 breast cancer cases. And you can see with breast cancer, it goes down a little bit. You can see some pair. So what's plotted here is every dot is every pair of observers, and except for the last one where it's all 17 observers. This is every set of 16. This is every set of 15. Every set of 2, and there's millions of them, so only 100 are shown, can range between 0.9 and 1. It's pretty good. Every set of 3, 4, etc., all the way down. But the plateau is at about 85 or 90%. So for estrogen receptor, we can do this. How about for Pdl1? Well, this is Pdl1 in lung cancer. If we just look at greater than 50% versus anything else, needless to say, the fewer categories you have, the better you're going to agree. So if we only had 2 categories, we actually had pretty good agreement. And this is what we do every day in lung cancer, is we give greater than 50%, or we say less than 50%, but sometimes we divide the less than 50% because there's still some indications for greater than 1%. But if we lose a 3-category assay, it drops down pretty significantly. So enough about lung cancer. Let's talk about breast cancer. So here's the breast cancer for SP142 for an honest plot of 19 readers, all expert breast pathologists, but explains the conundrum. You can see 2 readers can get 95% concordance, or a different 2 readers might only get 55% concordance, depending on where they are on this scale. But how will it perform in the real world? In the real world, it will probably perform at about 45% concordance, which is probably unacceptable. And you can say, well, SP142 isn't relevant anymore. Here's SP263. Interestingly, it's a little tighter, but it ends up at the same place. And if you don't want to use honest plots because you believe that that's just something crazy Rim made up, you can look at the ICCs for these, and the ICCs for these assays are below 0.6. So probably not a very good assay, and we shouldn't have high expectations for an assay that has an ICC below 0.6 telling us the real answer for a biomarker. So in summary, I would say the analysis by overall percent agreement of a number of observers illustrates how the SP142 or 263 performance in Impassion 130 could show 95+% with 2 observers, but in the bigger studies in lung cancer showed very poor, very low ICCs. Immune cell assessment, even with only 2 categories, appears to be non-reproducible in lung cancer and breast cancer. And reading immune cells, and probably CPS, although we don't know, we haven't done this study with CPS yet, amongst pathologists in the real world setting seems to me to be unlikely to be reproducible. So I'm very concerned about the recent approvals. CPS greater than 1 versus CPS less than 1, maybe like estrogen receptor, will be reproducible. It was for head and neck squamous cell carcinoma using the FDA's 3 comparison criteria or 2 observer criteria, whereas CPS 20, even with only 2 observers, was not approved by the FDA. So perhaps there's hope, but it's probably only for a positive or negative score. And so I wish I had time to go through all the analytic parts, but probably I think I got the key points in here, but I'll now open up for questions. Thank you.
Thank you, David. So in the interest of time, I just ask you one question. So how do you see the way out of this sort of quagmire around the Pdl1 testing?
I'm glad you asked that, because I think that Pdl1 is actually a great biomarker. And I agree with Elizabeth that we need to have other biomarkers too. And my lab has been testing RNA signatures, and we're testing multiplex fluorescence and assessing the TILs and lots of other ways of assessing the specimen. But those aren't there yet, and they'll never get done in these pivotal trials. It's really hard to bring a new companion diagnostic test because you can't do the statistical interaction test, because it's no longer ethical to have a placebo arm in any of those studies that where the drug is approved. But if we try to just look for associations, which we can do, I think ultimately, if we have a quantitative test for Pdl1 and we quantitatively measure it in either the stroma or the tumor, it will work. And we're piloting that now at Yale, and I hope we'll convince some other people to do it quantitatively and not rely on tests that are just poorly designed and probably not appropriate to have human readers. And so I predict, my prediction for the future is that Pdl1 it is the target. It will be an important part of future companion diagnostics, but only if it's looked at using objective methods.
That's great. Thank you, David. So I'm going to move on and introduce our last speaker, who is nobody else but Priyanka Sharma. So Priyanka probably won't require any introduction for this audience. She is our co-chair for the breast committee and a terrific investigator who's going to review the new immunotherapy trials which are in the pipeline at the NCTN. Priyanka, so I give the screen back to you.
Thank you, Lajos, and wonderful talks by both Elizabeth and David, and really eye-opening to see all the nuances and issues with Pdl1 testing that we rely on so heavily to make critical decisions for our patients, at least with metastatic disease. So I'm tasked with reviewing ongoing and upcoming trials. And the idea is not to go through an exhaustive list of every trial available on clinicaltrials.gov website. Just kind of go through some key concepts and ideas that are in development or about to start that are addressing some of the knowledge gaps. These are my disclosures. So as we design studies to evaluate new questions, it's taking into consideration the existing data that we have from completed trials, from historical reviews, and taking into account the biology of the cancer and looking at knowledge gaps, and then coming up with the trial design with an eventual outcome that we're seeking is improvement in patient survival. So before I start reviewing some of the trials, I just wanted to go through the knowledge gap, especially in high-risk early stage triple-negative breast cancer. And most of these were pointed out by Dr. Mittendorf in her talk. The key questions is now we have pembrolizumab approved for patients with early stage triple-negative breast cancer. Should all patients be treated with 3 to 4 drug polychemotherapy when immunotherapy is included in the regimen? Do we have any selection biomarkers to de-escalate chemotherapy when immunotherapy is going to be included in the preoperative regimens? Can some patients avoid anthracyclines or platinums? What is the role of adjuvant immunotherapy when a patient's already received preoperative immunotherapy in the setting of either residual disease or in the setting of PCR? Do all patients need both chemotherapy and immunotherapy? We certainly don't yet have biomarkers that denote preferential immunotherapy sensitivity, and Dr. Mittendorf pointed that out to us. It would be nice if we could select patients that were going to have that preferential benefit from immunotherapy when added to chemotherapy, but we don't have that. Can we identify patients that are likely to have excellent outcomes with chemotherapy alone, such excellent outcomes that it is unlikely that any additional escalation of therapy will improve those outcomes any further? And of course, as we look through all of this, there are, I think, at least in the immunotherapy for early stage breast cancer, knowledge gaps regarding long-term side effects of these agents in curative setting, the impact of cost, and patient and advocate perspective as these drugs are newer to our armamentarium. So before I review some of the planned studies, one study that I want to point to your attention is NACBP-B59 or GBG-GEPAR duos. So this is very similar to Keynote 522 trial, has the same chemotherapy backbone like 522 of carbotaxol, followed by AC with or without atezolizumab, followed by an adjuvant atezolizumab to complete a year. This trial has completed accrual and has dual primary endpoints of PCR and EFS, just like Keynote 522. So looking through some of our knowledge gaps and questions, can anthracyclines be avoided in some patients? Do we have any selection biomarkers to de-escalate chemotherapy when immunotherapy is going to be included in the preoperative regimen? Tumor-infiltrating lymphocytes, or TILs, can perhaps serve as a biomarker or a selection criteria for de-escalation and optimization. We know from many studies that increasing TILs is associated with higher PCR with neoadjuvant chemotherapy, and we see that with different types of neoadjuvant chemotherapy regimens, so it's not tied to a particular drug or a regimen. We also know from a nice meta-analysis led by Shireen Lloyd that increasing TILs are associated with better prognosis in patients who were treated with adjuvant chemotherapy. Thus, TIL enrichment can identify chemosensitive disease for which perhaps shorter, less intense chemotherapy regimen may be adequate, and giving these patients longer, more intense regimen may not provide them any added benefit. Approximately 30 to 40% of patients with early stage triple-negative breast cancer demonstrate stromal TILs greater than or equal to 30%. And that's kind of similar to the Pdl1 positive population that we see in the metastatic setting that we're all used to now using as a selection criteria to prescribe immunotherapy. So within SWOG, we have been working on developing a concept to de-escalate or optimize chemotherapy in patients with early stage triple-negative breast cancer that harbor high TILs using a cutoff of 30%. This is the trial schema. The trial will be for patients with T2 or T3N0 disease or T1, T2, N1 disease with TILs greater than or equal to 30%. The randomization will be between the Keynote 522 regimen versus carbotaxol pembrolizumab. So either the whole regimen or just the first part of that regimen followed by surgery. And this is after the recent approval of pembrolizumab, assuming that these patients that meet the criteria for 522, many of them are going to be receiving the 522 type of treatment regimen. The post-surgery treatment is going to be guided by pathological response. Patients who have a PCR will be advised to not receive any further adjuvant chemotherapy, regardless of the arm that they were initially randomized to. And those with residual disease will be receiving additional chemotherapy. All patients will be recommended to complete the year of adjuvant pembrolizumab based on the current approval, unless there is future data that suggests that some patients may not need this additional therapy. The primary endpoint of the trial is EFS. And the hypothesis is in patients with TIL-enriched TNBC, the platinum taxane chemoimmunotherapy is non-inferior to the taxane platinum anthracycline-based chemoimmunotherapy. A similar trial, a smaller one with PCR as an endpoint, is being conducted by the Breast Cancer Trialists Group in Australia and New Zealand and IBSG. As you can see, this is using a similar carbo-paclitaxel backbone with nivolumab as the checkpoint blockade. And the primary endpoint of this study is PCR. This is being led by Dr. Shireen Loy. This trial is about to complete accrual, so we'll probably hear some preliminary results from this study very soon. Our colleagues in SOLTI are also working on something in the similar space, again, looking at TILs as a criteria to select patients for de-escalating chemotherapy when immunotherapy is part of the neoadjuvant systemic therapy regimen. They're using a 20% as a cutoff, again, a 12-week preoperative regimen. And the primary aim of this study is to show an IDFS of greater than 92% in patients who achieve a PCR. So it's a single-arm study. At the entry, all the patients get the same treatment, and those achieving PCR are anticipated to have a really good outcome, even though the preoperative treatment was short and less intense. This current trial design does have a randomization built in after PCR to study the very important question of, is there any benefit with additional immunotherapy after achievement of PCR with pembrolizumab completion for 9 more doses or not. So this trial is not open. It's a concept in development, but I thought it'd be nice to kind of look at what others besides here, us in the US and NCTN are thinking about. And there are a lot of similar ideas regarding chemotherapy de-escalation. So what about the role of adjuvant immunotherapy when neoadjuvant systemic therapy already included when patients have received neoadjuvant systemic therapy? So SWOG 1418, led by Dr. Pushtai, just recently completed accrual. So thank you to all of you for supporting this study. This is a randomized phase 3 study that included patients with residual disease of greater than 1 centimeter or positive nodes. And patients were randomized to either pembrolizumab for a year or observation, as all of these patients were enrolled after completion of standard postoperative adjuvant therapy. So this trial has completed accrual, and hopefully in a year or so, we will hear the results and know how immunotherapy works after preoperative chemotherapy in setting of residual disease. What about immune checkpoint blockade after PCR? And this is, I think, a burning question for a lot of us. Patients who have a PCR have excellent outcomes, and it may not be possible to improve these outcomes further by additional therapy, at least not in all patients. In Keynote 522, in the adjuvant phase, after surgery, the incidence of grade 3 to 5 immune-related adverse events was about 3%. So it's not small, and some of these immune-related adverse events are permanent. We also saw that in GEPAR-NEUO, there was improvement in IDFS, and this trial did not include adjuvant immune checkpoint blockade. Again, IDFS was a secondary endpoint of GEPAR-NEUO. And if we are to study this question, what would be the optimal trial design? Should it be a non-inferiority trial design? Should we design this as a superiority trial? Should this be a single-arm study showing that patients with PCR do very well without any adjuvant immunotherapy, just like it was done in APT? What kind of patient selection should it have? All patients, or should we restrict this question to those with lower clinical stage, perhaps node-negative disease? And these are all good questions and perhaps cannot be incorporated in one trial design. So many groups are working on trial designs to address this important question, including our colleagues within NCTN. None of those were mature enough, trial designs were mature enough for me to share with everyone, but this is being actively worked on. Moving on to a little bit away from triple-negative breast cancer, how about ER-positive breast cancer, especially in early stage? What is the role of these agents? Can we identify patient populations that might benefit from this approach? We've learned from the metastatic studies that at least in combination with chemotherapy, this approach is not very fruitful for unselected patients. But early stage setting is a different disease and maybe more immunogenic. As we look for patient selection, are there overlaps with those likely to benefit from chemotherapy? Should this be studied in neoadjuvant or neoadjuvant plus adjuvant, as some of the triple negative trials did? And what should be the appropriate endpoints? So within SWOG, Dr. Cobain and Dr. Pushtai are co-leading this effort through SWOG 2206. Which is a randomized trial of neoadjuvant immunotherapy plus chemotherapy versus chemotherapy alone for MammaPrint ultra high or MP2 ER positive HER2 negative stage 2 and 3 breast cancer. And really the rationale for this trial design come from 3 different cohorts of I-SPY 2. And then this is data from Dr. Pushtai, so I'm repeating some of his work. That suggests that the MP2 high subgroup is highly chemosensitive, particularly so when exposed to chemotherapy and immunotherapy combination with the PCR of 64% noted in the Durva Taxol olaparib arm. And the MP2 high subgroup derives minimal benefit from endocrine therapy, but derives substantial benefit from chemotherapy and demonstrates similar immunogenicity compared to the non-MP2 high group. The durvalumab in the I-SPY 2 cohort shifts the RCB to the left in ER positive, HER2 negative breast cancer with the MP2 high phenotype, just like we see in HER2 positive disease with the addition of pembrolizumab and with the addition of pertuzumab, and in triple negative disease with the addition of pembrolizumab. So as the whole curve shifts onto the other side, the outcomes are improved, even though substantial improvement in PCR may not be seen. So this is the proposed trial schema of S2206. This is a trial for selected patients with MP2 high as an integral biomarker. So all patients enrolling into this study would have central testing for MP2 high, and those that are high would be randomized to receive standard neoadjuvant chemotherapy with or without durvalumab. The primary endpoint of the study is IBCFS. Skip over this. So in addition to the SWOG effort, there are other studies that are looking at neo and adjuvant immunotherapy in ER positive disease. And these are the 2 big trials are from pharma. Keynote 756 is looking at pembrolizumab in addition to neoadjuvant chemotherapy in patients with ER positive HER2 negative breast cancer, those that have T2 or higher disease, and the additional requirement is for grade 3 disease. This trial, just like Keynote 522, has PCR and EFS as co-primary endpoints, and Checkmate 75L, similar to to the Keynote study, again looking at nivolumab with or without standard chemotherapy. They're also requiring grade 3 tumor or grade 2 with low ER positivity. These are both very large trials of 1,200 patients each. And at least to my knowledge, neither one of these studies have completed accrual yet. So as we move towards the new era of immunotherapy trials in early stage breast cancer, I think it will need to be a combination of all of these factors that have to be put together as we design these studies and bring them to our patients and our oncologists. Thank you. And again, this wasn't an exhaustive list of all available trials, just some key highlights.
It's great. Thank you, Priyanka, for this really amazing review of the field. So in the interest of time, could you put back the agenda? I think we will need to move on.
So I think we have about 5 minutes for questions. If there are any on the chat, I hadn't seen any. If not, then we will move on to the next section, and the next slide's actually up here, which is publication update by Dr. Barlow.
Priyanka, can I just say something? This is Beth again. Something just very quickly. One of the hats that I have the privilege of wearing is as the co-chair of the Bio Task Force. And And what I would just like to, as you all consider your trials, and obviously you are thinking about this and what your great presentation, the NCTN, we need to be thinking about the trials that we can do versus what pharma should do. And these are vastly different. So I just throw that out there as you all begin your SWOG meeting and think about the direction you might want to take your IO portfolio.
Yeah, and I think hence the question of omitting additional immunotherapy in those with PCR, and even trials looking at chemotherapy de-escalation. I mean, as you said, you know, if the pembro is approved for all patients with any chemotherapy, then pharma isn't really going to have any incentive in looking at which chemo drug we can perhaps spare.
That's right. Yeah, they don't want us to give less. That's for sure. So
yes. So no, that is, I think, one of the key things. I think the challenge is there's so many good questions to ask, and it may not be possible to encompass all of them in one trial design. Although from an efficiency standpoint, that might be desired.
So again, if you have any questions, then please put into the chat box and I will read it out. So far, I don't see any.
So let me ask you this, Beth, since we have you here. So you mentioned lymph node status as perhaps some way to tease out who we should be prescribing all of this to. So at your institution, are you all using some criteria to prescribe pembro with chemo too, or is it just everybody over T2 disease?
Yeah, so we've had two conferences where we've discussed this, and you know, at first the suggestion was clearly anybody who is node positive and tumors 3 centimeters or greater. The more recent discussion has been that, you know, anybody 2 centimeters or greater node positive. What I was showing you was just something that I thought was interesting, and that was that some of the tumors that are slightly smaller, the T1Cs, they actually, if they go to surgery first, end up being node positive. So do we want to not have given them immunotherapy? So that was what that was about. The bigger conversation at our institution is the chemo backbone. Do you have to use the Keynote 522 regimen? And then even the sequencing of, do you want to give the anthracycline first or later? So like all of your groups, we're just working to try to figure it out. But that was a point of my slide, was that, you know, some of these T1Cs, 20 or 15% of them or so are going to be node positive if you look for it. Mm-hmm. So what we're thinking about is whether or not we'd want to institute an SOP whereby these patients with T1C N0, clinical T1C N0, would have a routine axillary ultrasound to look for the disease. We're debating.
It's also, I think it's important to recognize that nodal status or tumor size has nothing to do with actual sensitivity to any therapy. So right. You wouldn't give somebody HER2 targeted therapies because they have 7 positive nodes. Right. So I think the absolute benefit is what's changing, because the absolute risk is changing with nodal status.
Right.
Yeah. And I think that's, you know, now with the Keynote 522 with 5 drugs, that's just quite intense. So we're all looking for some way out, and it's a lot of it is data-free zone.
So I'd like to thank all of our speakers for the contributions to the seminar, and taking time to really review the field so exhaustively.
So we will move on.
Thank you, Beth. I understand that you will need to log off because of another commitment. And David, you are welcome to stay, of course. So Bill, if you would be updating us on the publications.
Sure. Want to go to the next slide, please? So a publication from Dr. Paoletti looking at serum thymidine kinase 1. In our SO226 trial, we actually had sequential measures of TK1 here, and it was highly prognostic, suggestion of prediction. And it's just appeared online about a month ago in Clinical Cancer Research. Next slide. This one I might have mentioned last time. It was in online, now it's in print. looking at risk factors for bisphosphonate-associated osteonecrosis from our 307 trial. Next slide. This used some of the data from the San Antonio presentation last December from a responder, and it's an editorial about using gene expression signatures. Next slide. So Dr. Klinsky's manuscript has been accepted for publication. It is under embargo, so we can't even mention the journal other than it's a major medical journal. And we don't have a publication date, but we expect it to be fall of 2021 under this title. And some further results from responder will be presented as a presentation at San Antonio. It's actually now a scheduled time of Wednesday at 10:15 at meeting, which will include some secondary outcomes such as distant disease-free interval, and will include some further information about ovarian suppression. This is a trial that we closed early with only 37 patients accrued because it was no longer viable to finish the trial, but it actually has some interesting TM results, and a revised version was invited by Clinical Cancer Research. So we're working on that currently. Next slide. The next manuscript for a trial that we have to get out is SWOG S1416. We're going to update the overall survival in that and also hope to have it submitted this fall. And this will be, Dr. Spears presented this work at our TM meeting. So it uses next generation sequencing from S8814 and will be included in the Spotlight poster presentation at San Antonio, which is going to be Thursday morning at between 7 and 8:30. And I think that's it. Thank you.
Thank you, Bill. Next, we have an update from Jeannie and Elda, our patient advocates. Just while they're coming on, just a general announcement for those of you who that are on the schedule to speak, please watch out for invitations from the IT folks running the meeting, inviting you to be the panelist that will enable you to unmute yourself and open your video. Let's see, Elda and Jeannie, I see that you're on.
Yes.
Okay.
Yes, I'm unmuted too.
Okay.
I think Jenny's first.
Yes, hi, I'm Jenny Mason. I'm with the Inflammatory Breast Cancer Research Foundation and serve on both the Breast Committee and Digital Engagement Committees for SWOG. You'll note we have a lot of things on our slides just to give you highlights of some of the things we do with both SWOG and outside of SWOG. So if you contact us to do something and we say we can't get to it right that moment, it's because of all these other things on our plates as well. Just so you know that I'm also I'm a breast cancer survivor of inflammatory breast cancer. So our trials that are specific to IBC are particularly of interest to me. I also am a survivor of endometrial cancer. And I serve on some other clinical trial groups like TBCRC. And right now my time is very heavily taken with the Advanced Breast Cancer Conference that was supposed to be in Lisbon next month, but we're doing it virtually. So we're recording talks. I have another one to do tomorrow morning on chemo brain, or as is said in Europe now, uncle brain, realizing the endocrine therapies and other treatments can cause cognitive problems for patients. I'm particularly interested in the brain and leptomeningeal kinds of initiatives that we can look at in SWOG because I'm working with a brain metastasis task force with the Metastatic Breast Cancer Alliance and realizing what an unmet need there is there for patients who are experiencing active brain metastasis for clinical trials. Most trials don't include those patients, and we're looking at places that might be willing to do a separate cohort, even if it's not going to give some of the information to perhaps identify a drug for moving forward in the process. It might, in its intended intent, it might be very useful in that subgroup of brain metastasis. Both Elda and I have been working with the TRACER trial as members of the External Stakeholder Advisory Committee. And I believe we have one more meeting with that group. And it's been a really interesting opportunity to work with a different group within SWOG to give input to a trial that's quite different from those we normally work with. I've got some other things listed there on my slide, but suffice it to say that we both really appreciate the work we're able to do with SWOG. I did mention in a previous meeting this week, we now have community advocates as part of the patient advocacy committee for SWOG. And those folks are available to help us with trials, to give input. They represent groups like veterans, rural populations, young adults, diversity, a number of different areas. So don't hesitate to ask us if you would like some input from someone who represents a community in the cancer arena that we may not have as much experience with. Thank you for the opportunity to work with you. Elda.
Thanks, Jenny. I'm Elda Rayleigh. I'm co-founder of Research Advocacy Network in addition to being a SWOG patient advocate. And it's been my pleasure over the past 6 years to be that voice of the patient, even though I'm not a breast cancer survivor. I'm a neurosurvivor, if you will. I had my first mammogram when I was 23, and the story goes on from there. But anyway, just to tell you a little bit about Research Advocacy Network, because that's a lot of where my days are spent, but there's an intersection of what we do at Research Advocacy Network and what SWOG does. Our intent is to improve patient care, just like yours. We do this in a number of different ways. One of the things that we have done is conduct research to help provide the patient perspective, which is often hard to capture in a formal way. We have had several publications, and I'd be glad to share that list. But one example that's listed here is our clinical trial endpoints paper that was published in Cancer in 2020. We also have a poster at San Antonio this year on risk of recurrence and patient perspectives on that. I'm also director of the Advocate Institute, where we train advocates to be better advocates and to work more efficiently with you. In that capacity, we've developed curriculum and training programs for cancer research advocates, started with a tutorial series that now has 9 titles. We have online courses. And today we did a session on health equity that we're doing a very robust course, online course for advocates to look introspectively at their intrinsic biases and some of the things that we carry into all the decisions that we make. And of course, on SWOG, I'm part of the breast cancer committee and very proud to be that. But like Jenny said, the days get very full. And so if we have to delay any of your requests, we apologize for that. But just know that we are very proud to support you and want to do anything we can to help you, because you're doing great work.
Thank you, Elda and Jeannie, and we see now that your plates are so full, and we appreciate you devoting your time to the SWOG breast committee's research activities and helping us with our new concepts and continued help for patient engagement and recruitment for our open trials. So next we will move on to Translation Medicine Subcommittee update to be provided by Dr. Thompson and Dr. Godwin.
Thanks.
Having some
technological
issues. Resolved. Okay, good.
I apologize. I think I had this meeting open twice because it's been so interesting. I've been learning so much. On behalf of Andy Godwin, who I'll hand over to in a moment, and myself, we just wanted to update you in no slides at all and a couple of sentences as to what's going on. The first thing is we're very grateful to those who are working very hard to deliver translational medicine work from the SWOG trials, despite the difficulties with timelines and multiple permissions that are needed to use the clinical material. And we always thank those who help us through the process, particularly Kara Laubach in the past, and now Alicia, who's working with us. Despite the timelines issues and the funding difficulties we sometimes have, we wanted to flag up a couple of things to you. The first is that there are 3 trials, RxPONDER, the everolimus trial 1207, and the triple negative breast cancer trial 1418, which are really just coming to the point where there's going to be particularly interesting translational medicine work to do. So please reach out to the principal investigators of those studies if you have an interest and want to get involved. Secondly, we meet from time to time, every couple of weeks, Bill Barlow, Andy and myself, to try and support any ideas coming forward. And we're particularly keen if there are newer investigators, colleagues that maybe want to start to get involved with SWOG a little bit more, who have translational medicine ideas, we're there to support you. And by way of thanking all of those who are supporting the translational medicine side of things, I'm going to hand over to Andy, who organized the translational medicine subgroup meeting earlier on today. Andy.
Yeah, thanks, Alistair. First of all, I want to echo Alistair's point that we want to really be very open about inviting new people into our committee, and really want people at your sites. If there are people interested, please reach out to Alistair and myself, because we'd like to have some new people come in and understand some of the resources we can bring, and have, just mentor some of the younger individuals who have new ideas. The other thing I did want to highlight is that Bill Barlow did a nice job of basically assembling all the resources we have in regards to samples, and that we do have a really wonderful amount of samples that can be used for a lot of translational studies. And so we do want to emphasize that, we don't want these samples to sit. We'd like to have them used and new ideas. And so that's one of the things that we're very much interested in. And then in regards to bringing in biotech, it's really a place that we're trying to bring in new biotechs, people with have interest in working with members of SWOG. And we had a group today that spoke, and they're very interested in working with members of our group. And I would emphasize those that have concepts, have partnerships with biotech, to bring them towards Alistair and myself, that we can also help try to mature those interactions to really move them on, because we do need both the kind of partnership with biotech that can bring in some of the funding needed to do some of these larger studies. But overall, it was a very productive meeting, well attended, and I think we've got a lot out of it today. And I do see a number of interesting studies on the horizon.
Thanks, Andy. And with that, I think we'll hand back to you, Priyanka. Thank you for giving us the chance to update you.
Thank you. And really the meeting this morning showcased the extensive number of projects and the diversity of different types of projects that are ongoing, that are being planned within the TM committee. And certainly we appreciate Bill and our protocol coordinator, Alicia's support for all of this work. And I want to echo what Dr. Thompson and Godwin already mentioned, that we're really looking for and inviting junior and mid-career faculty members to join the TM committee and bring up ideas. 3 large trials that were mentioned have all completed accrual. 1 reported out, the other 2 will report out, and so a rich resource to study many interesting questions.
Thank you.
Next, we will move on to our section of reviewing open SWOG and CTSU trials. And this is a list of trials that we will review. And I'm hoping those that are presenting these studies have all been invited on to the panelists, so they're able to speak. So the first one is 1706. Before we go to 1706, actually, I just wanted to bring this 1418 up and thank you and give a big thanks to all the committee members for supporting this very important study that completed accrual quite rapidly and nicely. So thank you, all of you, for supporting this study. And at the end of this meeting, you will hear about a concept that we hope will replace this study for similar patient population. So moving on to our open studies, S2007 is Dr. Brenner.
Yeah, thank you. Next slide. So just a reminder of 2007, this is for patients with brain mets who have HER2 negative breast cancer. They must have had CNS progression after prior CNS directed therapy. So either radiation, surgery, or any combination thereof. And then the rest of the requirements are relatively reasonable in terms of no seizure activity, modest steroid requirements for symptoms. And we activated this in December, and the first site that was activated in January. And we have about 172 centers and affiliated sites currently. Next slide. So as I mentioned, the first site was activated in January. We've had 4 patients accrue to date. This is, we've been a little slow to get going, and I'm planning to discuss with all the study champions to see if they have any additional suggestions on their end. And I'd be interested in hearing if anybody else has any suggestions, including our patient advocates. Anything that might get the word out about this study so we can get it accruing a little bit faster. We've seen typical AEs, 1 grade 3 white blood cell count decrease and 1 grade 2 neutropenia. Nothing that was unexpected. So if you haven't activated this study, please consider doing that. And if anybody runs into any barriers in terms of accrual, please let me know. I'd like to see this one move a little bit faster. And if anybody has any suggestions, please let me know.
So this is one of our new studies, and we encourage you to just keep it in mind as you look at your trial portfolios. Most of us don't have many studies that we can offer to our patients with progressive brain mets. So it is really providing that option to our patients. It's a small study, so we would like to get it accrued soon, so the early signals can then be evaluated for a larger trial. Next, we have 1706, and I am not sure if
I'm here.
You're here. You made it.
I am. Yes.
Yes.
I don't have a video unmute option, but I am as unmuted as I can be. So I'm happy to present an update. Oh, look, it says join as panelist now. Sorry, I was just promoted to panelist and that took a second. So I'm very happy to present the update on SWOG 1706. Next slide, please. As a reminder, this is our randomized controlled trial in patients with inflammatory breast cancer who are being randomized to either standard radiotherapy after standard neoadjuvant chemotherapy and modified radical mastectomy, or standard radiotherapy with a radiation sensitizing dose of olaparib. We are planning for 300 patients. We have 90 so far. Our goal is 5 patients per month. Accrual has been a little bit slow. It sort of hovered around 3 per month on the average. You can see there's a lot of noise in the data, but sort of hovering in that range, which is okay, but not great, and we would love to do better. And so we are going to be trying to reach out to patient advocates across the entire network and try to really promote interest in enrollment to this important trial in this rare disease.
Thank you, Dr. Jaxie. And again, for those that have the study open, just keep it in mind. Again, there really isn't another study that is competing for local regional therapy for patients with inflammatory breast cancer. We understand that this is not the most common patient population that we see, but for those patients that are seen, please think about this study.
Also, congratulations, Reshma, for the wonderful presentation that you did and the discussion after the plenary session.
Thank you. Thanks so much.
Yes, truly wonderful. We enjoyed it.
Very kind. Thanks. Oh, and this is me too.
Yeah.
I can unmute my video, but now you can see me blushing. So this is also a very important trial that we're championing, which is the Canadian MA39 Taylor RT trial, which is looking at regional radiotherapy in patients with biomarker low risk breast cancer. I guess there have been a number of amendments to broaden eligibility. And so if you go to the next slide, I think the easiest way to see this is with my red line.
So I think that slide just gave some glitches, so didn't make it.
Oh, my red line slide didn't make it. Okay, so I had a red line slide that like crossed out everything, but basically every eligibility criterion has been modified. So we now allow T3N0 disease. We now allow micromets. We now no longer require only one positive sentinel node after mastectomy. You're allowed to have two, and you're allowed to have additional micromets beyond that. What else has changed? The threshold for an Oncotype DX score is no longer 18. It's been increased based on an analysis of NSABP trials retrospectively to, I believe it's 25. Don't quote me on it. Sorry, it was on the other slide.
Yeah,
it's 25. Yes, and the windows between mastectomy or breast conserving surgery and treatment, or between chemotherapy, if that's being received, and treatment have been lengthened, all of which are intended to promote accrual. It's just a really important study because we do think that, although radiation techniques have advanced so much in recent years, if there are some patients whom we can spare the entirety of the experience of post-mastectomy radiation, and also in whom we can spare regional nodal radiation after lumpectomy, where at least in the United States, not very many people are giving shorter courses when they're treating the regional nodes. So it is a bigger burden for our patients. It really is an important thing to identify whether we can de-escalate treatment in this group of patients. So please do continue to refer patients. You guys are, I know SWOG is a largely medical oncology group, and so you guys are the ones that are seeing these patients and can really be an important referral source to maintain that robust accrual up to the desired N of over 2,000 patients.
So is the amendment with all the inclusion criteria changes through, or this is going?
It's through. It's through. So it's not pending. It's through. So sorry. The other side had the correction, so I thought that was going to show up, so you would actually see the new criteria. I'm really sorry, but this is the old criteria. What I verbally presented to you is the new criteria.
So it's a lot more liberal and really mimics what is happening in the real world and clinics, like
exactly.
Threshold of 25, the T3s that are being talked to or considered for regional RT. Okay.
Exactly.
Thank you.
And micromets now too, and lots of patients.
Patients, yeah. Next we have COMPASS studies, EA1181, which is the COMPASS PCR, which will be followed by A011801. So COMPASS PCR is Dr. Tang?
Yes. Hi. Can you hear me?
Yes.
Good. Yeah, this is a de-escalation trial, COMPASS EA1181, and basically the patient will get it's a HER2-positive trial. Patient will get a THP pre-op followed by surgery. Those who have PCR, they'll continue on the EA1181, and they'll have 1 year of HP instead, and radiation endocrine therapy as appropriate. And those who do not have PCR, they'll go on to the residual disease. And the recent amendment is that Amendment 4 is currently active as of July 2021, and minor clarification update, including allowance of recently approved FESCO as sub-Q injection was allowed. And currently there are 780 active sites per CTSG, and not all are enrolling though, but they have the potential. And we want to thank all sites who are enrolling given the potential stressor of the continuing pandemic.
Thank you. I think this trial is doing quite well and is enrolling close to 50 patients per month. So really shows that there is a significant degree of patients and provider enthusiasm for embracing chemotherapy de-escalation trials. So thank you to all of you for supporting this study. The sister trial to that is the COMPASS HER2 residual disease. Dr. Murthy is our SWOG champion.
Hi there. Hi, everyone. Can you hear me okay?
Yes.
Okay, perfect. Well, so this is the COMPASS HER2 residual disease trial. This is for patients with residual disease after neoadjuvant chemotherapy and HER2 targeted therapy. Of note, for ER negative patients, any amount of residual disease is allowed, but ER positive patients are required to have lymph node positive disease at this time. Patients are being randomized 1-to-1 to TDM1 and placebo times 14 cycles, or TDM1 and tucatinib times 14 cycles. Primary endpoint is invasive disease-free survival. Next slide. So this was activated early this year, and to date, early October, there were 52 patients enrolled. It is also opening in Canada via CCTG pretty soon. And there is an amendment coming through to include patients who received a de-escalated regimen off of EA1181. So those who received THP times 4 as a standard at their institution or center. Also an amendment coming forth to include patients with weakly ER positive disease, which would be really important on this trial, even if they have node negative disease. So ER 1 to 10% and node negative.
Thank you, Dr. Murthy. Again, an important study, and looks like it's off to a great start since it just activated, looking at improving outcomes for patients with residual disease after preoperative HER2-targeted chemotherapy treatment.
Thank you.
Next, we have BR004, and our SWOG champion is Dr. Cobain.
Hey, everyone. So just we'll review the BR004 schema, and then I'm going to talk a little bit about an amendment that just went through in July in an effort to increase accrual for this study. So this is a trial for patients first-line metastatic HER2-positive disease. They're stratified by prior adjuvant or neoadjuvant trastuzumab, prior pertuzumab or neratinib, ER status, as well as Pdl1 status. And patients are randomized to either standard taxane-based chemotherapy plus trastuzumab and pertuzumab and placebo versus that same combination with atezolizumab, so immunotherapy. And if you go to the next slide. So this is the status as of just about 10 days ago. So the number of sites approved is 559, 313 of which are NCORE sites. The cumulative number of patients that have been screened so far is 220, and the actual accrual is 134 out of a goal of 600 patients for this study. So currently only at about 22% of the accrual goal. And then you can also see the breakdown. We in SWOG have only accrued 6 patients to this study so far. Currently the accrual is about 8 patients per month. So that's about 20% of the projections. The goal is really to try and get this to about 20 patients per month. And then just a couple of notes about the current population that's been accrued to the study so far, about 78% with de novo metastatic disease, only 2 patients currently with brain metastases. So there's been an amendment that was just activated July 30th of this year, really in an effort to increase accrual to this study. So one of the major changes is now that docetaxel is allowed as a chemotherapy agent. Previously, it was paclitaxel only. The other factor is that patients actually are able to enter based on the local HER2 status, at least initially. There will still be central confirmation of HER2, but that isn't required, just to enter, screening to enter the study initially. And then also, it used to be that patients could get the loading doses of trastuzumab and pertuzumab while they were awaiting randomization, but now the amendment allows not only for patients to get those loading doses of the monoclonal antibodies, but also to get the first 3 weeks of chemotherapy treatment while awaiting the confirmation of the HER2 status and the Pdl1 status prior to randomization. The hope is that this will increase accrual, because I know that there was some hesitancy about just giving the monoclonal antibodies to patients that are, sick and perhaps, could have imminent organ dysfunction if not treated with chemotherapy plus the monoclonal antibodies promptly. There's also some loosened restrictions on the eligibility criteria for brain mets. I won't go through the whole exhaustive list, but just kind of a short version. Patients that have 4 or fewer brain metastases are eligible. They have to be asymptomatic from their brain metastases at the time that they enroll to the trial. Leptomeningeal disease is not permitted, and patients also must have measurable disease outside of the CNS in order to qualify. And then one other note that's just important is that use of Phesgo is not actually permitted in this current amendment. Contracting is underway, but this will be something that's possibly brought forth in a future amendment. So right now it is still the IV formulations of trastuzumab and pertuzumab within the context of this study. So really want to try and encourage people to think of this trial for patients with first-line metastatic HER2 positive disease. We'd love to see this trial increase accrual, largely because I think if we're not reaching that 15 to 20 patients per month by the first quarter of 2022, this study is in danger of closing.
Thank you, Erin. And it looks like the recent amendment should make it easier. So it's taking care of a lot of the logistic issues and concerns that were perhaps hindering patients and their doctors for considering the study, especially the central testing of things and waiting for that when most of these patients can have access to really effective therapy right away that's standard of care and available. It's also interesting to see almost 80% of these patients enrolling are with de novo metastatic disease. Again, testament to the fact that the early stage HER2 positive disease, we're doing a much better job of curing that.
Yeah, so I was just going to say as well, it's a more rare population to have them be treated for early stage disease, and then
then recur. Thank you. Next, we have A01102, Dr. Maman.
Thank you, Priyanka. So presenting 11202, Alliance 11202, which is Judy Bowie's trial. So this is a trial for patients who have T1 to 3 invasive breast cancer who are node positive at the time of diagnosis, who then go on to get neoadjuvant chemotherapy and end up being clinically node negative. They undergo sentinel lymph node biopsy. And if the sentinel lymph node comes back positive, they're randomized in the operating room or postoperatively, depending on when the results come back, to either a completion axillary dissection followed by adjuvant state level 3 and superclave radiation, or no axillary dissection and axillary and superclave radiation. So there was since the last time we met, there was an amendment for tissue collection that went through. Otherwise, no major changes for the trial. You can see the top accruing sites there. SWOG has been contributing to this accrual, as you can see, so thank you very much. And we're almost over the line. And so the goal is 4,812, and when we checked earlier this month, it is 4,108. So another 700 subjects needed for accrual. So the anticipation is late spring or summer for this trial to complete accrual.
Thank you, Dr. Maman, and thank you for all the investigators for supporting this study. So it's almost there. Moving on to SWOG 1501, to be presented by Dr. Floyd or Dr. Leah.
Actually, this is Hallie Moore. Dr. Floyd wasn't able to attend today, so I'm stepping in for him. I think he gave you a slide with the schema, which, so S1501 is a randomized study evaluating carvedilol versus no intervention and looking at an endpoint of cardiac toxicity for women with HER2 positive metastatic breast cancer who are at risk for cardiotoxicity. This previously was a 3-arm study in which there was a 3rd arm with patients who were already on a beta blocker or a similar medication and were observed. That arm has fully accrued. So now we are only including patients who are not on these medications already and will be randomized. The study is moving along. I think there's a second slide that looks at the accrual. And so you can see it's maybe getting about a 1/3 or so accrued. They are actively looking for additional sites. It's a very easy study to put patients on. There's a little bit of startup challenge with getting your echo lab validated, but once that's done, then everything goes very smoothly. And actually they've figured that all out so that happens pretty smoothly as well. The other updates are that now up to 4 lines of HER2-based therapy are permitted. So you can enroll patients who are well into their treatment and they do not have to be just initiating that line of HER2-based therapy. So you may have a lot of patients in your practice already who could pop out of this trial at any time. Hopefully, Accrual with other groups will pick up. There's been a lot of work discussing this trial amongst the other cooperative groups, and Dr. Catherine Reddy from Mayo will be a champion for Alliance. And so if anybody has an interest in opening this, please do. If it's already open at your site, please look through your patients getting HER2-based treatment for metastatic disease.
Thank you, Dr. Moore. So next we have S1714, which is a prospective observational cohort to study a predictive model of taxane-induced peripheral neuropathy in cancer patients. Dr. Trivedion.
Yes, I'm here. Thank you. Thanks for letting me give a brief update.
Dr. Trivedi and Dr. Mammon get the prize for consolidating all of their information in only one slide. I ask everybody to submit 1 to 3 slides, and almost everybody submits 3, but the two of you consistently manage to get everything together in one slide. Thank you
for that. So I also have the good news of saying that this study is almost completed accrual. We're expecting that at least by the end of the year, if not within the next month, we should be complete enrollment for this study and then hopefully begin analysis. So thank you to everyone who's submitted patients to this trial, and we look forward to sharing the results.
Thank you for great support for this study, and hopefully in the upcoming meetings, we'll get to hear some results. Next, we have SWOG 1703, which is a randomized non-inferiority trial comparing overall survival using serum marker-directed monitoring versus usual care in patients with metastatic hormone receptor positive breast cancer. It's led by Dr. Accordino and Hirschman. And Melissa couldn't be here today, so I'm going to present this on her behalf. So the study has been open for a little bit and is not accruing as well as we had hoped for. So steps to improve accrual are following champions from Alliance has been identified, and champion from ECOG Akron will be identified to help solicit support from other groups to improve the visibility for the study. And then there's also ongoing discussions to look at the non-inferiority margin and adjust that and see if the total sample size can be decreased. These are the current enrollment numbers for step 1, which is the step 1 registration and step 2 registration. So I would encourage you to look into this study as an option for your patients. I think initially the trial required all 3 tumor markers, but that was since then changed. So that helped, and hopefully with the additional efforts, this trial will see some improvement in accrual. Next, we have NRG BR007, or the DEBRA study. This is a brand new, recently activated study, and I think Dr. Shamoon is our SWOG champion.
Yes, thank you. Thanks so much for the opportunity to talk about this. Can you hear me okay?
Yes, thank you.
Okay, great. Yeah, so many great studies that we're discussing today. This is one study that I wanted to bring your attention to as a very important a study that's asking a very important question about the role for radiation therapy as part of breast conserving therapy. So this is a study that aims to identify the lowest of the low risk patients and see if they will have very low rate of local recurrence after surgery and endocrine therapy without radiotherapy. And so this is a very favorable group of patients, age 50 to 70, tumors that are smaller than 2 centimeters, ER positive and HER2 negative, resected with negative margins and surgical axillary staging, who have a low risk oncotype score defined as less than 18, and then are randomized to standard of care with adjuvant radiation endocrine therapy versus endocrine therapy on its own. And this is a non-inferiority study that's looking at ipsilateral breast tumor recurrence as the primary endpoint at 10 years. It's a study that has the potential to be a very impacting study, a landmark study in radiation oncology, and would encourage you to consider opening it at your institution. As Priyanka was mentioning, it is recently activated. It's been approved at 150 sites roughly, and would very much appreciate your support of the study at your institution if you're able to open that.
Thank you. So we are also looking at opening this study. We're not activated yet as a site. So for a lot of the sites, it takes us 2 or 3 months to activate the study. But for us, it was an active discussion with our radiation oncology and surgical oncology colleagues within our working group to ensure that we can fit this in with other local therapy studies or IORT or other modalities that were available. But it can be done. So it just requires a good discussion to ensure that we can identify patients for the study.
Yeah, thank you. And let me know if I can be helpful with any of those discussions in opening the trial.
Thank you. Next, we have EA1183 to be presented by Dr. Linden or Dr. Specht. Hi.
Thanks for letting us present this trial.
Hannah, I think you're still on mute. Perhaps IMS can help. IMS, can we unmute Dr. Linden?
Priyanka, maybe you could move on to the next item. And if Dr. Linden is able to join, then we will.
I think she joined, but it's just her audio. There was an issue. But let's see, while we're working on that, let me move forward to TMIS, and we'll come back to EA1183. So TMIS, Dr. Arun.
Yes, hi, thank you. Hello, everyone. A quick update on the TMIS. I'm the champion for SWOG. As you know, this is a large prospective study in asymptomatic women presenting for screening mammograms between ages 45 and 75 that are randomized to undergo have either breast tomosynthesis or a digital mammogram. The goal is to recruit close to 165,000 women. Next slide, please. Next and last slide. The the endpoint is really to identify breast cancer determined by biopsies during the follow-up. And the follow-up will be 4.5 years, and this rate will be compared between the two arms, the digital mammogram and the tomosynthesis. Accrual to date, as of just last month, September 2021, information given to me by Dr. Etta, they are at 55,000, close to 56,000 patients. So I think it's going well.
Thank you, Dr. Arun, for championing the study.
Thank you.
We'll try to go back to 1183 and see if we've been able to address technology issues. Dr. Linden, are you able to join us? If not, I will give an update. So this is a trial of FDG PET to assess therapeutic response in patients with bone-dominant metastatic breast cancer, and has enrolled 57 out of the total enrollment of 134 across 24 sites. And so it's doing reasonably well for a trial that's relatively new. The trial schema that's primarily looking at the FDG PET as a measure of response. I think Dr. Linden also wanted to acknowledge all the sites that are actively contributing to the patients, and she has a list of top enrolling sites. So the next section we have is reports from all our committee liaisons, and we have radiotherapy first, if Dr. Jaxie is still on.
I am. Hello. Wonderful. Sorry, I had to take off my half mask. So I'm pleased to update you on progress on several other things. So you heard about the champion studies by Dr. Shumway of BR007 and from me about MA39. In addition, we have a couple of SWOG studies that are making their way through. Eileen Connolly is continuing to lead a very important concept of IORT for DCIS, status post-breast conserving surgery, and she has been awarded a Hope Foundation grant. So huge congratulations to Dr. Connolly for that accomplishment, and plans to get her concept revisions back to DCP by December of this year. Dr. Corey Spears is leading a concept that we've discussed in the working group before about CDK4/6 inhibition concurrent with radiation therapy for locally advanced breast cancer. And so that's continuing to work its way through processes of what may be feasible right now. And then we also have some secondary analyses underway, including a very important secondary analysis that was pre-planned of radiation therapy use and local regional outcomes by recurrence score and radiation therapy receipt on the SWOG 1007 trial. So Dr. Kolinsky and Professor Barlow are actively enmeshed in that. And then finally, Dr. Spears is also leading the way in looking at genomic signatures, as you've already heard, within the context of 8814, including genomic signatures and local regional outcomes. So those are all the radiation-related updates. And of course, please continue to accrue to 1706. Thank you.
Thank you. So it looks like a lot of active things going on despite the challenges of a pandemic and not meeting face-to-face. Dr. Chakpur for surgery update. And if she's not on yet, I know Banu, you were on, so perhaps you can give the prevention update while we look for others.
Yes, sorry. One of the updates, Reshma already gave the update about Eileen Connolly's DCIS study. The other study we want to mention is S1914. That's Kathy Cruz decision support to increase chemo prevention, informed choice among women with atypical hyperplasia and lobular carcinoma in situ. As of September, again, 109 out of 200 providers were enrolled and 66 out of 115 patients accrued. So the study is ongoing and I think it's meeting its target.
Thank you. Dr. Chakpur, Dr. Irvine, Hirschman.
So it's Hallie Moore. I'm stepping in also for Melinda Irwin.
Okay.
Hi. So can you hear me okay?
Yes.
Yeah. Okay. So for the survivorship committee, I'd just like to give a plug for tomorrow's meeting, which will be 9:30 to 11:30 Central Time. We have an excellent speaker, Dr. Eric Zhao from Harvard, and he'll be presenting on insomnia in cancer survivors. Obviously a very common concern for our breast cancer survivors. And it would be great to see some study concepts developed in this area. We also continue to look for ways to include survivorship questions in the therapeutic trials that are being developed. So please reach out to Melinda Irwin or myself if you're interested in developing something in one of the trials that is currently being developed. And again, we appreciate your support of S1501, which is really our main survivorship study that relates to breast cancer.
Thank you. I can't really see all the attendees since I'm sharing my screen. So if Dr. Lammers is on or Dr. Hirschman's on, Dr. Chu's on, please unmute yourself and provide your updates.
This is Lynn Henry. I can provide the update on symptom control and quality of life if you'd like.
Yes, that'd be great.
Okay, so thanks. You've already heard about some of the studies that are ongoing in our committee, but there's a few others I wanted to highlight. One is 1614, which is looking at hepatitis B reactivation in patients with solid tumor cancers, including breast cancer. So now that HBV screening is considered standard of care for patients who are undergoing chemotherapy according to the ASCO guidelines from last year, please consider enrolling patients in this trial if they have chronic or past HBV. We also have SWOG 2013, which is looking at immunotherapy, immune-related adverse events. Now, admittedly, this is limited to patients who are getting immunotherapy without chemotherapy, so there aren't going to be that many patients with breast cancer who fall in that category, but please keep that trial in mind. And then two upcoming trials that we have. One is SWOG 2010, which is going to look at active symptom monitoring in young women with breast cancer who are starting endocrine therapy plus ovarian suppression or ablation. And this is an R01 hopefully funded trial. We're still waiting for the notice of grant award that will get started later in 2022 and will be open to NCTN and NCORE sites. There's also a study from Melissa Acquadino, SWOG 2205, that's in development looking at an intervention for chemotherapy-associated neuropathy. And then finally, for anyone, especially junior investigators who are interested in getting involved in patient-reported outcomes analyses in breast cancer trials, please let me know or let Don Hirschman know, and we'll try to see if we can find a project for you to work on. So thank you.
Thank you. We look forward to hearing more on the upcoming trials, especially young women on endocrine therapy and symptom management. So we'll move on to our next section, which is a review of some of our developing concepts. We'll start with Detect-01, which is now SWOG triage approved, so has a SWOG number of 2202, and I believe Dr. Kalinsky will be presenting this.
Thank you, Dr. Sharma. So this is a study that we've been discussing that I'm championing along with Dr. Bardia, and Dr. Bave is the TM chair. Next slide. So this is looking at, this is a phase 2 trial of in patients with minimal residual disease in the adjuvant setting for triple negative breast cancer, and investigating for those patients who have detectable cell-free DNA, giving the TROP2 antibody drug conjugate sacituzumab govitecan. This is the design. So this is for patients with stage 2 or 3 triple negative breast cancer. If they were treated in the neoadjuvant setting and they have residual disease, they would be eligible. All of these patients, when they go on, will have completed surgery, and radiation therapy if it's indicated, and all of their other systemic therapy, whether it's immunotherapy, chemotherapy, and or PARP inhibition. So patients will enroll within 18 months of their definitive surgery for triple-negative breast cancer and have no clinical evidence of metastatic disease. We would start screening for cell-free DNA utilizing the bespoke assay from Natera. If at any point they become or have detectable cell-free DNA, then they receive sacituzumab govitecan for a total of 8 cycles. And you can see if they do not have detectable cell-free DNA, then we will continue to monitor every 6 months for a total of 2 years. If they do, and they go on to receive sacituzumab govitecan, we will continue to monitor their cell-free DNA, again, up to 2 years, and also have imaging as well. The primary endpoint is clearance of cell-free DNA at 6 months. And then there are a number of secondary endpoints, including looking at relapse-free survival at 2 years, both in the cell-free DNA negative group and those that are have detectable cell-free DNA. These are the objectives. As I mentioned, we're looking at clearance of cell-free DNA. There are a number of secondary objectives, looking at the positivity rate. Also, I didn't mention if patients have detectable cell-free DNA, then we'll do imaging at that time and look to see if they have asymptomatic metastatic disease. And we're estimating that that rate's going to be about 10 to 15%. We'll also look at safety, tolerability, and compliance. As I mentioned, recurrence-free survival. And we'll also be collecting additional specimens for future correlative studies. Next slide. These are the eligibility. As I mentioned, patients would have triple-negative breast cancer, stage 2 or 3, or they receive neoadjuvant chemotherapy and have residual disease, must have an appropriate performance status. And as this is the bespoke assay from Natera, then we would need to have their tumor tissue with which to base this cell-free DNA testing. Next slide. Just additional eligibility, including having appropriate labs if they have detectable cell-free DNA, do not have metastatic disease, and then would go on to receive sacituzumab govitecan. Next slide. And these are the statistics. The primary endpoint, as I mentioned, is clearance of cell-free DNA, and we felt that having a 33% clearance rate would be clinically meaningful, with 20% being the null hypothesis. We anticipate that we'll have 30 patients with evaluable, who will be evaluable, who will receive the sacituzumab govitecan. We do power for looking at relapse-free survival in the cell-free DNA negative compared to the positive population. We did set some feasibility rules for a subsequent randomized trial, including the having at least 10% of those having detectable cell-free DNA in the first 12 months and 5% in the first 6 months. And also a second requirement that at least 2/3 of patients who receive sacituzumab govitecan would remain on therapy for the prescribed duration. Next slide. And as I mentioned, we're also collecting additional samples such as serum and Streck tubes that we will be sending to the SWOG repository. Next slide. So just as an update, we have confirmed support from Natera and Gilead. As Dr. Sharma had mentioned, this is SWOG triage approved, and we've submitted this to CTEP. Next slide.
So I think next we will have a polling question, and we really would like all our participants and audience to actively participate in this, because we anticipate this study being ready to enroll in the next few months, and we want to make sure that we're engaging all of you. So the way you respond to the poll is either you go to the website that's listed up here, and if someone from IMS can cut and paste these instructions in the chat, that'd be great. I can't do it while I'm sharing my screen. And you can either use the website or you can text and provide your response. You text to the number 22333 and text the word Courtneyville 940, and that will bring you in the poll, and then you can respond to the questions. And let's see if this works. If it doesn't, I may have to reset the program. Okay, it is working. So will you open this study at your institution? This is SWOG 2202, the phase 2 trial of sacituzumab in patients with ctDNA positive disease. And here are your options. Actually, I'm going to extend the time for response. We have 7 individuals that have responded. I am sure there are more than 7 in our 109 participants that take care of patients with triple negative breast cancer. Okay, I think the poll is locked. Out of those that responded, many support the study, and there are few that had maybes. And if we could hear from those individuals, you can raise your hand from using the icon on the bottom of your screen, so we can unmute you or type your concern or question in the chat. Really, this trial is a stepping stone for a larger randomized study that we hope would replace the very successful SWOG 1418 study. So we'd really like to hear from all of you, our members who will support these studies. Okay, I don't see any raised hands or chat questions. Of course, you can reach out to Dr. Kalinsky and Dr. Bardia personally if you want to discuss this further. Thank you, Kevin. So next we'll move on to SWOG 2206 to be presented by Dr. Cobain. And Erin, I'm sorry, I stole some of your thunder by presenting some of the slide schema earlier in my talk.
No problem at all. We'll move through the background relatively quickly since you mentioned it earlier. So the S2206 study, really the main objective is to test if the addition of durvalumab, a PD-1 inhibitor, to standard of care neoadjuvant chemotherapy may improve invasive disease-free survival in a subset of patients with ER-positive, HER2-negative stage 2 and 3 breast cancer. And that subset is really defined by this genomic ultra-high risk by the MammaPrint assay, or the so-called MP2 subgroup. So as I mentioned, the primary endpoint would be invasive disease-free survival. Secondary endpoints of interest include pathologic complete response rate and quality of life measures. And then we also have a variety of exploratory biomarker endpoints. Next slide. So this is the study schema as it currently stands. So ER positive, HER2 negative patients with stage 2 or stage 3 disease that are really thought to be as chemotherapy eligible by as per standard of care. So that could be because they have locally advanced breast cancer at presentation, are node positive and premenopausal, or we may identify patients for this study based on the fact that they have high genomic risk by the Oncotype DX assay, so recurrence score greater than 25, or of course by MammaPrint if they are MammaPrint high. Should mention that MammaPrint is provided free within the context of this study. And if they are MammaPrint high, really what we're hoping to identify is this ultra high risk, this MP2 subset. And if patients indeed fall into that category, they would be randomized to receive either standard ACT chemotherapy or the chemotherapy in addition to durvalumab. And then patients will ultimately go on to surgery and receive standard of care endocrine therapy in the adjuvant setting. Of note, this study does not include durvalumab in the adjuvant setting, so no adjuvant immunotherapy. Next slide. So this is just a description of the screening eligibility and then ultimately the eligibility for treatment randomization. So as we've discussed, ER positive, HER2 negative, stage 2 or 3 breast cancer for whom chemotherapy is indicated. So it may be that patients have a high Oncotype DX recurrence score greater than 25. If they've had MammaPrint, ultimately we're looking for that MP2 ultra high subgroup. Could also be premenopausal women with node negative disease and a recurrence score of 16 to 25, if the physician feels that they are going to be recommending chemotherapy for that patient. Or premenopausal women with known axillary lymph node involvement at presentation. Patients could be clinically locally advanced with either T3 or T4 disease, or matted N2 and 3 disease, or histologic grade 3 cancers. And then of course, patients have to have no known contraindications to receiving chemotherapy or immunotherapy treatment. And then once we're looking at the randomization, they must be MammaPrint ultra high MP2 status. Again, that is provided free, that assay within the context of this study. And they must have no evidence of metastatic disease. Next slide. So Lynn Henry is going to be leading the effort on this study with regards to the quality of life objectives. So we're really going to be looking at changes in the global physical health or PROMIS global health score in patients in the chemotherapy alone versus the durvalumab arm. Also going to be looking at severity of fatigue, global mental health, changes in global physical and mental health and fatigue from with subsequent treatment. And then finally, the severity and the frequency of treatment-related adverse events. Next slide. This was the original sample size calculation. Dr. Barlow yesterday mentioned that the sample size is going to be slightly greater than this based upon our new estimates and the desire to have about 85% power. But just want to walk you through kind of the thought process behind this. So approximately half of MammaPrint high cancers fall into the MP2 subgroup. There is an 88% concordance between recurrent score high, so recurrent score actually greater than 30, and the MammaPrint high status. And about half of all newly diagnosed ER positive, HER2 negative patients undergo recurrent score testing corresponding to about 95,000 new patients per year in the United States. About 25% of recurrent score results are greater than 25 in the estimates that we have available. And sorry, just want to fix this really quick. And then adding patients with locally advanced disease and stage 2 ER positive cancers in premenopausal women to those that have recurrent score greater than 25, we estimate that the total pool of screen eligible patients is around 35,000 per year.
So I think there's a question in the chat, Erin, regarding what proportion of patients would be MammaPrint ultra high. So I think based on the information that you provided, if it's a practice or a site that's routinely used to just doing oncotype, which many of us are, to determine who we're going to recommend chemotherapy to, then it's a safe assumption that in half of those patients where you see a recurrence score of 25, you will see an ultra high.
Yes, because there's pretty good concordance between high oncotype and high MammaPrint, and then about half of the MammaPrint high cancers are ultimately in this MP2 category.
So half of the total number of patients that you are currently prescribing chemotherapy to would be eligible for this, and given that some of these we're prescribing post-operative chemo as opposed to preoperative chemo, so might require some shifts in how these patients flow through the sequence of their treatment.
Exactly.
As this trial is available.
Exactly. So we have to think about ordering these assays, earlier than we would otherwise if we think that patients may be potentially chemotherapy eligible in order to see if they may qualify.
Mm-hmm. Yes.
So the current status is that this has been approved by SWOG triage as of mid-September, and we're currently in the process of preparing the submission to CTEP. We did have some conversation yesterday in the breast working group meeting about how we need to think about this trial now in the context of the recent FDA approval of adjuvant abemaciclib for those patients that have high-risk ER-positive disease and a Ki-67 greater than 20. So we may choose to incorporate that as a stratification factor within the study, and we're, I think, going to be having ongoing conversations about that. So we developed this concept and, of course, even prepared these slides before that recent FDA approval. So more to come as we have more discussions about that.
I think the question asked by this trial is somewhat independent of the escalation of endocrine therapy. It just, if a lot of these women are going to get the CDK4/6 adjuvantly, we have to project a slightly survival. Or
exactly, we have to project how that would impact, right?
So we'll move on to 2206 poll question. And actually there is a comment from Dr. Henry on the chat stating that Dr. Kang is actually the QOL PI for 2206. So Dr. Cobain and Kang team is going to be leading this study. So we'll move on to a question. It's very similar to the previous question. So it's simple. Will you open this study at your institution? Yes, no, because you have a competing study, or you just don't like the design, or you don't think you'll have patients for it, or you're thinking about it and you haven't made up your mind. I'll extend the poll on this slide and see if we have a little bit more engagement. So I suspect for sites that have I-SPY 2 open, this will be in somewhat of a competition. I don't know, Erin or Laish, if you want to comment on that.
Yeah, so for sure. I mean, this would be a competition for any neoadjuvant trial that enrolls ER-positive patients. So I think what's really sort of exciting about this study is that among the ER-positive patients who we select for chemotherapy, it's really a minority that seems to be benefiting from adding IO therapy to it. And that minority just happens to be the group that is the least likely to benefit from the endocrine component of their treatment. And Erin has showed you these slides that the estrogen receptor-related signaling is very low in these cancers. And many, many studies have shown, in fact, these are parts of the recurrence score assay, the mammoprint itself, and that's the reason why they are high. Because these ER signals are actually part of the current prognostic scores. So I'm very excited about this study because I think this goes after the population that's probably the least likely to be helped by the current therapies. And to what extent they are helped by abemaciclib, it's unclear, but certainly abemaciclib would come if they have residual disease. But again, they're actually aiming for a really high PCR rate as well. That's kind of unseen in the ER-positive space, around 60%.
So when mammoprint is ordered for I-SPY, would that report MP2 with it?
Yeah, I mean, we could actually probably discuss this with the I-SPY leadership. Currently, it's not reporting MP2 status, but it's measured and it's available in I-SPY prospectively. It's just not reported back.
So for sites that perhaps want to participate in both, and there's plenty of ER-positive patients that are receiving preoperative therapy, those that are MP2 high could be offered this, and the others could continue to go on the I-SPY 2 subprotocols.
Yep.
Okay, so the last new concept I will present on behalf of myself, Dr. Mitri, and Dr. Rim. You've seen a little bit of it in my talk earlier today. This is the TAC2, which is the TIL-adapted neoadjuvant chemotherapy optimization in triple-negative breast cancer. And over the last year and a half, many of you have seen many versions of the trial design and schema. And this is the most updated one. And the hypothesis is still the same, even though this new trial design incorporates immunotherapy, is that in patients with TIL-enriched TNBC, platinum taxane chemoimmunotherapy is non-inferior to taxane platinum anthracycline-based chemoimmunotherapy. So patients eligible for this study have to have T2 or 3T N0 disease or T1, T2, N1 disease, and TILs greater than 30% by central assessment. The arm A, which is the control arm of the study, mimics Keynote 522. So this represents the most robust chemotherapy backbone with immunotherapy, because if we're going to do a study to show non-inferiority of a certain regimen, we ought to compare it to the best available one. If we show non-inferiority to something that is a little bit less, then that question will always remain, well, what if your chemotherapy backbone had all 4 drugs, and maybe you wouldn't have gotten here. Both arms will include pembrolizumab, as it is now considered standard of care for these patients. The post-surgery treatment will be directed by pathological response. The primary endpoint is EFS, and the trial is targeting a hazard ratio of 1, but the upper bound must be less than 1.6 and requires a sample size of 954 patients. I think earlier, at least in our working group, we had some discussions about the central TIL testing. And since this is integral biomarker required for eligibility, it was felt in our previous discussions with CTAP and BIQ that this needs to be done centrally, since this is not routinely done in local pathology labs, and we wouldn't know what the concordance of different people reading the TILs is at local level till we actually generated some data. So during the course of this study, if it opens, we will start generating that data for local versus central TILs. And once that starts looking robust and reliable enough, there is an option that this can be the eligibility for TILs can be transferred back off to local sites. This TIL assessment does not require tissue per se to be sent. It just requires an image of an H&E slide to be scanned and sent over. Almost all of the standard image scanners that the local pathology labs have, that they often use for immunohistochemistry and other automated methods, are good for scanning the slide and sending. So we hope that that wouldn't be a big barrier for sites that can't do it, can definitely ship the H&E slide to Dr. Rim's lab, and it will be scanned over there. We anticipate the results to be reported back to the site within 3 working days. So these are just a summary of changes from the previous version that you might have seen. T1C is now excluded from it just because the control arm mimics 522, and T1C patients were not included in 522. So I'll move on to a poll question. So we have a few more responses on this question than the previous one, and a lot of you like the trial and would open the study at your site if this was available. There are a few maybes and few competing studies, and of course, for sites that do a lot of neoadjuvant, we always have competing studies in this space, so that's just the reality. If anyone wants to speak up, I think we want to hear from folks about the control arm of this study with the 4 chemotherapy and pembrolizumab. What are your thoughts? Is that something that you're comfortable randomizing patients to, or at your institutions, you're using a different chemotherapy backbone than what was used in 522? Any of our panelists want to chime in and provide their thoughts?
So maybe if you could put back the schema.
Yes, I sure can. Yep. So I know Kathy, Lynn, What are you
No,
doing at your
I
institution?
think we might actually have an opportunity to not do the pembrolizumab and then see what happens, because that's one of the questions that is pretty unclear. What's the value of pembrolizumab in either of these arms? So certainly in the PCR group, you could make a really logical conclusion that it's going to add very little, since we expect these people to do really well. In the residual disease group, it also is highly questionable. If the chemotherapy plus the pembrolizumab over 4 months or 3 months didn't eradicate the cancer, pembro alone probably won't do it. So also, none of the companies really suggest that you continue pembrolizumab after progression on the disease. So there is a lot of data that even a few courses of pembrolizumab after you stop for toxicity have a carry-on effect. So I think we have a chance maybe to look at what happens if you don't do pembrolizumab. The question is whether this would really discourage people from participating. So I would really love to hear from the rest of the group whether you would consider it a weakness if there is no adjuvant pembrolizumab.
And I think the other thing that we had discussed is there's upfront randomization, so it would require a second randomization if we want to ask that question methodically for the adjuvant therapy. So I think, most of us haven't gotten to the point where we have to give adjuvant pembrolizumab yet, at least not as part of standard of care. But a lot of the pathways and beacon plans are being built with what was in Keynote 522. That doesn't necessarily mean we have to prescribe it to every patient. But I would love to hear some of your thoughts about, is there a way to tweak or modify the trial design to make it more appealing, or address another question that you find burning? Oh, I think Kathy has her hand up. I think you can unmute yourself, Kathy.
I'm unmuted. Yeah, thank you, Priyanka.
Yes.
I think if you could, I think the study would be really attractive if you could do a formal randomization there and we could figure this out, because we're going to be stuck, aren't we, with doing this based on 522.
So this is a randomized design, yes.
No, not to give pembro post-surgery in the PCR.
Yes.
I would favor, if you could do it, make the trial bigger and more complicated, but still, it's an important clinical question.
Mm-hmm. Yes.
Maybe a secondary randomization after the surgery, like this 2x2 design for pembro versus no pembro.
I'd have to ask Bill if 2x2 would work here, if you just re-randomize at that point.
So we could re-randomize. This should be about 60% of the original group that has PCR.
Yes.
So there may still be a question of power to answer the question, but certainly a larger trial. And we expect that the event rate would be very low in this group, right?
Right, yes.
So it's going to be hard to actually show it's statistically different, but it would still be informative.
How about the residual disease group? Because, if it's supposed to work, it might be the group where it works the best. Although again, so there is no data that pembro, after previous progression on pembro, would be synergistic with the next line of chemotherapy in any disease setting, as far as I know.
Didn't Beth Mittendorf show earlier in, I can't remember back that far in her meeting quite accurately, that it was a node positive subgroup actually that had the benefit in 522?
Well, I think the highest delta,
PCR.
Yeah.
So I think the adjuvant pembro question right now, till we have data to say that it doesn't work, there might be reluctance to not give it, to randomize patients to not have it. For those with residual disease.
Right.
Yes. For those with PCR, of course, we're all motivated to not give any more. And I'm always wondering in those with PCR, if we can't re-randomize them, can we just ask for no pembro and follow them as a single arm? And that with about 600 patients would be would be a good enough sample size to demonstrate an EFS of greater than 92 or 93%. And just thinking about, what are the strategies can be used to ask this question. And of course, in those with PCR, neoadjuvant pembro, that question is relevant to all of the patients, not just patients with high TILs. I know Larissa is on the call, and I don't know if she has any thoughts or comments.
I'm happy to comment. I would say I would be more in favor of, if you're going to ask the question, that you ask it as a randomized question. I'm afraid that if you leave it as either physician's choice or no choice at all, that you sort of lose the, if you're not comparing to the regimen that was used in Keynote, in what your comparator regimen is, then I don't know. It just, the numbers start to get dicey. You have a little bit less ground to stand on. So I would say, I would, if there's a way that you can put in a second randomization, I think that would be okay. I do think there's studies in development in other groups, potentially asking that question in a broader population than just the TIL positive patients. So it may be that if there is a separate study that asks that question, the two could feed into each other.
Yeah, that's a good point. Yes. So in terms of the Arm A chemotherapy backbone, are there any objections to that? Major objections? Are most of you using this backbone with pembro, or kind of sticking to more ACT or TAC? Or haven't decided yet?
I actually prefer just the Taxol alone.
Followed by AC?
Yeah. And it's again, the iSpy showed the exact same thing as the Keynote 522, and it was sufficient just during the Taxol phase.
Mm-hmm.
And also the Gepar Nuevo just had not paclitaxel and had the same sort of improvement, magnitude of 7-8% improvement in PCR rates, and the remarkable improvement in event-free survival. So I'm not sure that the carboplatin is really a critical component.
I think it makes the design cleaner in a way, but I don't know. I mean, I think it's a hard question, because this is exactly what the Keynote regimen was, right? And so if you're going to prove non-inferiority, I think if you prove non-inferiority against this standard, then you sort of have you're definitely there. I mean, you could certainly argue if you can prove non-inferiority against ACT pembro, and a lot of people are using that, and you couldn't argue that ACT carbo pembro is worse than ACT pembro, then you're probably okay. So I mean, I guess you could do it either way, but I think that this does make it a nice, clean design.
Right, and then I think in speaking to a lot of community members, pretty much they're following 522. They're just kind of following it to the T, including every 3-week AC, because many of them are tied to pathways, and having only a couple of plans to choose from. You can't have 5 different, beacon plans that you build for every space. So even at our institution, we were told we just have to have 2. We can't have more than 2 pembrolizumab plans for preoperative therapy. So we all had to get together and agree on 2 regimens, and that's it. Okay, so that actually concludes our meeting. We're a few minutes early, and I'll hand this back to you, Lash.
So thank you, Priyanka, for running this so smoothly, and also for collecting all the slides. I also would like to thank Alicia, Randa, and Courtney, Willie, who reached out to each of you to distribute the websites and organizing the meeting in the background. So you did a great job, and thank you for that. And also our colleagues at IMS for providing the conferencing services. And ultimately, I thank you all for sticking with us for almost 3 hours, and for your support for the SWOG trials, and also for giving us sort of ideas and feedback. Although I recognize that an online venue is probably not the best and most efficient source to receive feedback from you, but I'm already receiving emails, and I and Priyanka and the rest of the leadership committee actually welcomes your feedback, and so it's for future trials and how to improve on the current concepts. So I thank you all, and I wish you a very good evening and weekend.
Thank you, everyone. Have a good evening. Bye.
Bye-bye.
Bye.